Good evening, everyone. We welcome you all to OrthoTV in association with Association of Spine Surgeons of India to introduce today's topic and the faculty. I hand over to Dr. Gautam Zaveri.
Good afternoon. Welcome on behalf of the Association of Spinal Surgeons of India. I'm Dr. Gautam Zaveri, Joint Secretary of the ASSI. Welcoming you to our Pro Series webinars. Today's webinar is on posterior cervical instrumentation, and what will be discussed is the various techniques using lectures of PowerPoint presentation as well as videos to explain the techniques of various instrumentation procedures in the occiput and posterior cervical spine. The entire session will be moderated by Dr. Vishal Kundnani, who is an eminent spine surgeon from the Leelavati and Bombay hospitals in Bombay. He has done an enormous amount of work on transarticular C1, C2 fixation, both in adults and children, and has a lot of publications on the subject, and is the ideal person to lead this eminent panel from across India, which is going to explain to you in detail from the basics, that is positioning of the patient in order to avoid problems, to exposure to the various surgical techniques, how to avoid complications, and go on to talk to you about the vertebral artery and its problems. So before I hand over the mic to them, I would also like to enlighten you about some of the other ASSI activities. The subsequent webinars after this, we have a webinar on Sunday, the 6th of December, and that will be on early onset scoliosis. The session will be moderated by Dr. Bhauk Garg, and we have some of the world experts on early onset scoliosis who will be joining us for this Master Series webinar. On Sunday, the 10th of January, we have a webinar on subaxial cervical trauma management, which will be moderated by Dr. Ankur Nanda. All these webinars are available on our YouTube channel, and you could access them through our YouTube channel at any point. If you are interested in some of the previous webinars, I'll go through the list at some point. You could also access them through our YouTube channel. In order to watch all the ASSI activities, follow us on Facebook, follow us on Twitter, and you will know about what is going on with ASSI. ASSICON 2021 virtual is going to be a big virtual conference. The annual conference of the ASSI is on January 29, 30, 31 in 2021. A week prior to that, that is on the 23rd of January, on the 24th of January, we have the pre-conference workshops, which will also be of great interest to you. Some of the highlights of the program this year, we have a 2.5-hour long session on newer and emerging technologies in spine, which is named as Navigating into the Future with Spine Surgery. We have two societies, the German Spine Society and Argentinian Spine Society, which are participating in our meeting as a joint session with the ASSI. We also have sessions dedicated to purely navigation in spine surgery, endoscopic techniques, post-operative imaging using MRI, a session specifically directed towards how to improve outcomes in spine surgery, and we have some masters like Larry Lenke who will be showing you various surgical techniques. The other sessions include case-based panel discussions on proximal junctional failure, pediatric spinal deformity, and complications in spinal surgery. Do not miss out on this program. Register for the conference as early as possible so that you don't miss out on this very, very exciting and entertaining event. As I was just mentioning that we have had, this is the 12th in a list of ASSI webinars. We've had previous webinars on various topics, initially on the cervical spine, then on scoliosis, lumbar disc, stenosis, and listhesis. And I would encourage you to go onto our YouTube channel and watch these webinars at your convenience, at your pace, so that you understand how to deal with these problems. The ASSI has also come out with a video journal where experts in spine surgery across India curate and point out 3 articles on a particular subject which have influenced their practice maximum. We started with Dr. S. Rajasekaran, our past president from Coimbatore, moved on to Sajan Hegde, Bhavuk Garg, and Mir Bapat, and we are looking forward to the next edition, which will feature our president, Dr. H.S. Chabra. The ASSI monographs are books dedicated to a particular topic in spine surgery, such as complications in spine surgery, etc. These are some of the topics. There are 8 different topics on which ASSI has published monographs, and these monographs are available through our websites, through the TM website, which is our medical publisher, and through Amazon. You can buy it at any time. The ASSI textbook on spinal infections and trauma, published through the JP Publishers, is available again on Amazon and available through the JP Publishers website. The Indian Spine Journal is a quarterly publication, and it features all the interesting work done in India across the year. All of you are encouraged to send in your scientific work to Indian Spine Journal. The journal is likely to be indexed over the next few months, and if it does get indexed, then all the articles which have been published will retrospectively be recognized in an index journal. So you must take this opportunity to publish in the ISJ. The ASSI in recent years has been reaching out to various second-level cities across the country. We have been to places like Udaipur, Jaipur, Guwahati, and conducted spine programs in those areas in connection with the local orthopedic neurosurgical body or spine surgery body. We would be very happy to have an outreach program in your city or your town. And if you reach out to us through your association, to our secretary, Dr. Ajoy Shetty, we would be very happy to hold an outreach program in your city. The ASSI e-learning program is an ambitious project by the president of the Association of Spinal Surgeons, where online spine education is being offered to orthopedic surgeons through a program curated by masters. So again, I request all of you to follow ASSI on our website, on our Facebook page, on our Twitter handle or YouTube channel, in order to find out about all the latest activities of ASSI, keeping abreast. I would also request you to follow us on our ASSI Connect, which is our interactive case-based discussion panel. And you could submit your own case over there, and that case could then be subsequently seen by various masters, and you could get a solution for your problems. So while this webinar is on, you will be able to see it on the YouTube and the Facebook channels. If you have any questions regarding any points regarding the techniques that are being shown, please feel free to ask through the YouTube channel. However, if you're finding it difficult to ask through the channel, you could write to me, Dr. Gautam Zaveri, at my mobile number on WhatsApp, 9820504351, and I will be glad to put it up to the panelists over here regarding whatever is the solution to your problem. So now, without much ado, I would like to hand over the mic to Vishal Kundnani to invite all the eminent panelists from across the country. Thank you very much.
Thank you, Dr. Gautam. Thank you, ASSI, for conducting this webinar on one of the most intriguing and one of the most challenging aspects of spine surgery, which is posterior cervical instrumentation. And just to bring out the overview of this webinar, we are going to be only talking about the technical tips and tricks that all these masters have been learning and mastering, the techniques of doing various kind of instrumentation while doing posterior cervical spine surgery, be it lateral mass screws in the subaxial spine, be it subaxial cervical pedicle screws, or be it C1, C2 screw fixation or transarticular screw fixation, and all the way extending the fixation to occipital bones, which can be either in the form of occipital screws or condylar screws. So we are going to be just bringing out this. Before that, may I invite all our panelists here to start with Dr. S.K. Srivastava, sir, the head department, KEM Hospital. Welcome, sir. We also have with us the senior CV junction surgeon, Dr. Mihir Bapat, who's going to be talking to us about C1, C2 fixation techniques. We have Naresh Babu from the central and Deccan Plateau of our country. We have Dr. Umesh and Upendra coming from the southern part of our country, eminent members of ASSI, joining us to give a hand and understanding about the complications and problems and cervical pedicle screws. With us, we have today the young chap from Bombay, the dynamic guy, Ayush Sharma, who's going to be talking to us about cervical lateral mass screw fixation. And of course, none other than Kshitij to take over the supraspinal part of spine, which is occipital screw fixation. And to top all this, the cherry on the cake is Neeraj and the OrthoTV team, who are going to be connecting to us, all of you, live through YouTube and also through OrthoTV channels here. So may I just invite, without much ado, to start the subaxial cervical spine fixation. May I request upon Ayush Sharma and Upendra Bin to please be ready. Ayush, your slides come up first with lateral mass screw fixation. Your time is 10 minutes. Ayush, your slides. You're muted, Ayush. Unmute, please.
So, can you see the slide?
Can, and hear you also clearly, loud and clear.
Yeah. So I'm starting now. So thank you, Vishal, and thank you, ASSI. Let's start with lateral mass fixation. Lateral mass fixation will be the workhorse of any spine surgeon when it comes to fixation of cervical spine posteriorly. So let's start with the basic one slide on anatomy. What is the lateral mass? So if you see the lateral mass, when we see from posterior, it looks like a square which is confined by the superior facet superiorly, the inferior facet here. The medial border is the junction between the lateral mass and lamina, and the lateral border is formed by the lateral border of the lateral mass. But actually, when you're putting the screw, you have to imagine it in a three-dimensional way. So basically, it is not a square, but a cube. And it is a cube in which you are putting the screw. So this three-dimensional anatomy is very important if you want to play a good, safe lateral mass screw. So when it comes to indication, as I told you, it remains our workhorse for any posterior cervical spine fixation from C3 to C7. You can use it in case of trauma like this. It could be a pure lateral mass fixation in this case of facetal subluxation, or it could be hybrid fixation, which is where lateral mass becomes a part of the fixation in this complex ankylosing spondylitis fracture. In case of degenerative spine, after laminectomy, you can use it to fix the spine, to hold the spine, to prevent further complications. You can use it as a posterior augmentation. If you have done a complex anterior surgery, maybe more than 2 levels of corpectomy. In case of infections, tumor, when the integrity of the spine has been compromised, then you can use lateral mass to augment and to support the spine. So you can use it anywhere and everywhere, wherever the anatomy allows you to do it. Are there any contraindication to using lateral mass? There are no absolute contraindications, but of course, there are some relative contraindications. Anything which compromises the integrity of the lateral mass, you should not use the lateral mass fixation. For example, it could be a trauma to the lateral mass, any pathology which destroyed the lateral mass, or it could be anatomical variation. So let's see a few cases. If you look at this patient, look at the lateral mass here. It's such a big 17 mm lateral mass. And we see the lateral mass on the other side. This lateral mass was only 8.2 mm. Look at the pedicle. It is 5.3 mm. So it was more easy, more safer to put a pedicle screw here than to do a lateral mass screw. Again, we wanted to put a lateral mass in C3, C4 here. But look at this lateral mass. It is just 10.7 mm. This lateral mass, if you are putting more than 12 mm, it could lead to an injury because the vertebral artery is just out there and the C2, C3 is already fused. So again, instead of putting a lateral mass, we chose some different type of fixations. Again, C7 lateral mass may be very, very small in few cases. So if the C7 is the end of a massive construct, something like this, then you're better off with a pedicle screw than relying on a lateral mass screw. Other thing, if you want to correct some sort of kyphosis in a spine, the lateral mass screw might not be very strong. As you can see in this case, a kyphotic correction was attempted, and obviously the lateral mass screw ultimately failed and it had to be augmented from anterior. So if you're trying to attempt any significant correction, if you want to hold a correction, lateral masses are absolutely fine. But in these cases, you need better anchors, maybe a pedicle screw, which will be dealt with later in this series itself. So let's talk about the insertion technique. There are so many techniques from Magel, Anderson, and Roy Camel. So if you look at the techniques, most of them, they have proposed, you start in the middle of the lateral mass and then you direct it laterally almost 25 to 30 degree, depending upon whatever the technique you choose. And the craniocaudal angulation is roughly between 20 to 30 degree. But let's understand what is happening here. Let's understand the anatomy. You can choose any technique, but why the techniques comes like this? So one of the beautiful things about lateral mass is because you are going away from the cord and you are away from the nerve root. So only thing which you are rarely likely to damage is the vertebral artery. So the technique is described, you start in the middle of this cube and you go like this. So the chances that you will likely to damage the vertebral artery becomes very, very insignificant. But again, understand, if this is the cube and you're using this trajectory, you're using a very small part of the lateral mass. So if you want to put bigger screw for whatever reason you choose, maybe some cases we want to put the largest screw, maybe 16, 18 mm screws, centimeters mm screws, then you can choose this trajectory. You can come down in the corner of the lateral mass and use the whole cube anatomy of the lateral mass to put big screws. Then, but you have to be careful not to come in the way of the vertebral artery, so your angle becomes more steep. So that is all about, you can choose any technique, any method you want to, but you should understand the logic of using the technique or the method. So, and this is one of the example where we could manage 18 mm screws using a steeper angle and starting at the bottom of the cube rather than the center of the cube. So as they say, failing to plan is planning to fail. Even for lateral mass screw or for any screw, you should plan your screws well. For example, this is a case example we did 2 weeks back where we wanted to do a C3 to C5 fixation and decompression from myelopathy. Again, this is the case where I showed you. So again, if you see the lateral mass here in C3, were not ideal to be placed. Again, the lateral mass on this side were very, very small. So when it comes to choosing lateral mass, it remains your workhorse. But the anatomy, you have to read, you have to look at the structure and then plan it. In some cases, the anatomy or the destruction of the lateral mass might not be suitable enough to put the lateral mass screw. So let's see a small video how to practically do it. So any technique starts with a good exposure. In case of lateral mass, I always prefer to take out the bifid spinous process before I start putting my lateral mass, because that hampers the angle which I can come. So what I'm doing is simply taking out the bifid of the spinous process so that I can come at a better angle. So if you see, this is the cranial end, caudal end. I am standing on the left side while I'm putting the lateral masses on the right side. So what I do is I'll mark the medial border. So this is the medial border of my lateral mass with a cautery, and I'm marking my entry point here, which is not in the center, but slightly down in the corner of the square. So this is what this is. So anatomically, if you see this, this is the medial border of the lateral mass. So this is the bone model, just to show you where I'm starting. So most of the time we use a high-speed burr. So this is a 2 mm burr I'm starting with. So you don't start at the bone with the burr. You start with full speed and go on the bone so you don't wobble off. And you start with you the angle of around 25 to 30 degree, but I have taken out the bifid spinous process. My angle could be even steeper if I want to be. My burr is sitting on the lamina, on the lower lamina of the vertebra just below it, so that I can angle it. And I just taken out the cortex, and even for the first screw, for sure, I'll check in the SIA to look if I'm at the right craniocaudal angulation. Most of the time, if you are sitting like this, you'll get a good angle. But still, it is wiser and better to check the craniocaudal angulation in the SIA. Now, I will go, I use my burr to go all the way, but if you see, I'm not going directly in. Every 2 millimeter, I'm coming back again, palpating if I have a bony end at the other end and going slowly. So every 2 mm, you can use a calibrated drill, but I use burr. And the time my burr comes to this part of the cone, so the tapering end of the burr, if you measure it ever, it comes to around 12 millimeter. So once I have gone here, so if you see, this is 12 millimeters. So once I have gone there, I know I have crossed 12 millimeter, and this end comes to 3 mm. So already I have, this part has been drilled 3 mm. So this is the time I'll again make sure where I am. So I am almost another 2 to 3 mm we can go, but this was good enough for this case. So, and then we will feel to make sure that the bony integrity is maintained. And once you have done that, you can again reconfirm your length by using the same probe to know the length of the screw which you want to put in. And this was, I think, 14 or 16 mm, which is what normally you will get. And if you use a steeper trajectory, you can go even up to 18 mm in case of a lateral mass screw. So this is the screw being put, and just for the demonstration's sake, we'll again check the angle. We have got a right angle in the C-arm. So this looks like a decent angle. And this case, this is the CT scan, and the screws were okay. So lateral mass screw remains our workhorse in subaxial spine C3 to C7. But you should also be aware of other screw like pedicle screw, and so that in difficult cases, in difficult scenario, you might choose them in case of lateral mass screw. Thank you. That should be it, Vishal.
Thank you, Ayush. It was wonderful elaboration from you. While Upendra sets up his talk, may I have one question from Dr. Sudhir Srivastava? Dr. Srivastava, so you saw Ayush doing his lateral mass. Is there anything different that you do? Upendra, while your slide's setting up. Dr. Srivastava? Yes, Dr. Gautam.
So there are a number of questions on our YouTube channel for Ayush.
Yes, please.
Ayush, the first question that has come from Dr. Modi is that would you do, if you had to do a laminectomy, would you prefer to do laminectomy first or screw fixation first?
So in most of my cases, as I showed you, this is a case where we did laminectomy. But first, I will try put my screw. The reason being, your dura is closed. You can, as I showed you, I can let the burr rest on the lamina of the level below. So that gives me a very stable angle. And even I can angle as much as I want when I'm doing the lateral mass. So only problem, what happens when you're doing your lateral mass screw first, is sometimes the laminectomy might be difficult if you have not started at a correct lateral margin. So you have to make sure you're starting lateral to the lamina. That is the only problem. But in most of my cases, I prefer doing a lateral mass fixation.
So I have a small suggestion. That what I do is I always make my holes ready, keep my holes ready, drill it all the way up to the second cortex. Like unlike Ayush's case, I always like to have a bicortical purchase, particularly whenever I'm adding a laminectomy. That not only gives the additional few millimeters. So keep all your holes ready, then perform your laminectomy, and then get your screws in, and then get your rod in. So that's the sequence that I follow. Is there any difference that
one step though? I do the same thing, but what I do is after making the holes, I finish drilling the entire lateral gutter, and I decorticate the lateral gutter, making it ready for the fusion. And then I put in my screws, and then layer the bone graft from the after doing the laminectomy. put the screws and layer the bone graft on the lateral gutter for a fusion. And then the last thing is the assembly of the rod. One of the things which we don't do is assemble the rod initially, because not only does it come in the way, but if you apply some compression distraction in a canal which is already tight or compromised, you may land up with a neurologic deficit. So therefore, the step, as Ayush very rightly pointed out, the first thing is to make your holes, or even put the screw. That is also fine. But before putting the screws, make sure you make a fusion bed which is adequate, because you are planning to. It's the goal of the surgery is not only instrumentation; it is to fuse that area. Otherwise, the instrumentation will eventually fail. So that is extremely vital that you prepare. The second question, Ayush, that has come from these people is again from Dr. Modi, is that the direction of the screw. Do you start off, when you start off, do you point in the same direction or do you change? Because with the burr, what we saw you do was that you went directly at an angle of about 25 to 30 degrees laterally and 25 to 30 degrees upwards. But practically what happens is, if you try to go in that direction, then the drill tends to slip a little bit and you end up breaking out of the posterior cortex.
So that is the trick. Initially, I used to go that I won't go in the angle, but now if you start with your drill in full power, then you won't wobble. That is what I use.
So what he means is dorsal burst out. What he means is dorsal burst out. Dorsal burst out. So do you want to go straight with the burr and angle your drill, or you want to go with the drill angled only? Because the chances of dorsal burst out, the dorsal surface of lateral mass bursting while a screw goes in, is there.
So that's why. So if you go with your drill in full speed, then likely you won't wobble out. So then, and if you made your trajectory, if you're in a good trajectory, you don't need to change your trajectory. So that's what I feel. And the chances that you will burst out is less. But again, if you start with the drill on the bone, then you will wobble out, and that is the problem begins. So you need to start with the full speed of the burr and then go drilling, and most of the time you will get it right. You will get the trajectory. Which
usually the angulation of the.
I think we'll just move on now. I think Ayush, it was wonderful. So the role of pre-operative planning, being ready with your armamentarium, being safe rather than sorry, having a good trajectory planning is imperative to lateral mass, and the indications of lateral mass are plenty. In fact, almost every second case in posterior cervical spine, I think lateral mass is a safe, effective and strong hold. As Ayush mentioned, it's the workhorse of posterior cervical instrumentation. We will come back to you, Ayush. Please stay back. We have plenty of more questions coming up. We'll be catching you again while we move on to a far more secure, little more ambitious and challenging technique, cervical pedicle screw. Over to you, Upendra.
Thank you. So I'll be speaking on cervical pedicle screws surgical technique. To put a cervical pedicle screw technique, we have to have intimate knowledge of the cervical morphometry. We need to know the entry point, and from the entry point, we need to know how much to angulate medially and laterally, given by the transverse pedicle angle and the sagittal pedicle angle. The pedicle width gives us the thickness of the screw that we can insert. Pedicle axis gives us the screw that we can put. Now, if you see the metric studies, most of them have shown that the inner pedicle width is than 3 mm in the lower cervical spine. The outer pedicle width is somewhere in 5 to 6 mm, and the transverse pedicle angle is somewhere between 45 to 50 degrees, except in C7. Apart from that, if you see the sagittal angle, the C3, C4 are slightly directed, and C5 to C7 are slightly caudally directed. The Indian studies by Dr. Srivastav, Dr. Rajshekaran, all have Indian pedicles also follow the same pattern. The Indians are having even lesser of width. So a 3.5 mm screw would be difficult to put in, and also children have been shown to take up about 3 mm screws. Preoperative planning is very crucial. Bhumi et al. Have always told that you do a routine CT scan along geography to see the vertebral artery as well as the pedicle sections. But in our practice, we have seen that MR imaging is quite useful. You can take images along the pedicles, see their architecture, and also see the vertebral arteries in the axial section the coronal sections. If there is any abnormality that is seen on the MR, then we go for a CT angio, or if we have a congenital anomaly, then we go for a CT angio. Coming on to the technique itself, the most common technique followed is the conventional technique described by Abumi. The entry point is just lateral to the center of the lateral mass, 1 to 2 mm below the superior articular margin, which corresponds to the notch of the lateral surface of the lateral mass. We decorticate the entry point, put our blunt pedicle probe at an angle of around 30 to 40 degrees and get into the cancellous core. Mind the point is quite medial to the actual axis of the pedicle. The lateral view will give you the craniocaudal direction. You can adjust this as was shown in the previous presentation. But we all know that it is not routinely used. One of the main problems is the excess lateral perforations that have been reported. If you see most of the studies, foreign evaluation, around 15 to 20 perforations have noted. Most of these perforations, almost 75 to 80 perforations are lateral. So that's quite concern for us. Why does this happen? Now, if you actually see the screws which we put are 3.5 mm and inner pedicle were between 2.5 to 3. So the has to encroach one of the cortex being thicker, the lateral cortex is easily perforated, giving rise to lateral perforations. Another reason why the lateral perforations are at a level is the trajectory of Abumi is at a lesser than the vertical axis. So even though our pilot hole is intact, the proximal medial tends to shift the cortex. What are the try more laterally, go through the axis at a steeper angle of around 50 degrees to prevent the medial cortex from hitting the screw laterally. But going 50 degrees medially is difficult and we need multiple stab incisions, which become quite cumbersome. The other option is if we can actually shift the screw medially. For this, we have to either drill the medial cortex or we have to curate it with sharp curettes to get a screw into the body through the medial cortex. Now, we described the medial cortical pedicle screw technique. It is very similar to Abumi technique, just medial to the entry point, and we go through a 2 mm or 2.5 mm diamond tip burr into the vertebral body, drilling the medial cortex there. Now, if you see the literature that is till date, you can have 3 sets of hand pedicle screw insertions. The first and the Abumi technique go in at an angle of around 30 to 35 degrees. The lateral vertebral notch technique, which aims to put the screw along the pedicle axis and at a steeper 50 degrees. The third group is where we utilize the screw by Ludwig in the funnel technique. Then the medial cortical pedicle screw technique described by our group. Then the medial funnel technique and the lamino. All of these utilize the cortex and the screw at around to 35 degrees, either drilling the medial cortex or curating it. Now, just to give you an overview, I have just taken 6 studies with more than 3 screw evaluations. The first 4 here are with the Abumi technique. You can see most of the perforations are similar, like say around 50% of total perforations in all these studies. You see the medial and lateral perforations. In the first 4 studies, you can see that perforations are somewhere between 70 to 80%. Compare that to last studies where you have quite lesser amount of lateral perforations. The last but one is our technique, medial cortical bird. This is the largest screw on the medialized screw. The last one by Pan et al. Is the largest evaluation of screws in the lateral. So both have given lesser amount lateral perforations. These are few of the examples. Now this is what I meant medializing the screw. If you drill the medial there will be few of the threads getting into the spinal column, but that is have quite a good amount of safe zone in the cervical spine. Now, indications, as we talked about, it can be used in any situation where we are using lateral mass, but do wear cervical pedicle screws when there is lateral mass? Now, the same question was asked when we did not have thoracic pedicle screws. So we were using the, so once we are comfortable with any technique and we have safety of it, technique which gives a 3-column rigid stabilization is useful than a posterior stabilization. So we can use it in all the situations where it is required to fix the cervical spine, fracture dislocation, or in a Angst bond with compression, where we can get good of long segment fixation by posterior only technique. In cases cervical kyphosis with, we can address it all posteriorly by compression and correction of kyphosis in a single setting. So obviously have been useful at least in certain situations, but should we restrict its use only to difficult situation? Mind you, when we use a difficult technique in a difficult, probably the failure chance more. So what we always intend is to use it in a routine fashion. So this improves our accuracy and also brings us more in difficult cases where it can be used more effectively, safer way. So to conclude, I would say that as of today, there is no single technique as standard. Abumi technique is the popular and the most followed one. Freehand technique has to be the cornerstone for insertion tool, have to guide the freehand technique, improve the safety when there is altered cervical anatomy. Do I have a time for around 1 minute video here?
Yes, please carry.
I can just show the video here. Yeah, this is coming out.
So while, yeah, okay.
Yeah. Here you can see one of the important things is you have to neutralize the head while you are actually instrumenting. It should not be in kyphosis. And you can see we have to have a quite wide exposure. The lateral should be quite good. You need to get a good amount of angulation here. You can see that we have taken out the retractor so that it doesn't come in the way of angulation of this. You can actually see the bone dust there drilling the medial cortex. So this is about 2.5 mm drill bit, which is going through that all the way, feeling the medial cortex. So in again, it's the same thing. You with your probe, then the screws. That should be fine. Yeah. I think I'll stop. That should be fine. Yeah, I can stop it here. Thanks.
Okay.
Thank you.
Thank you, Upendra. I think it was wonderful to know more about cervical pedicle screws. So while we have another speaker setting up things around here, Dr. Srivastava, what do you think why cervical pedicle screws have not caught up to the popularity despite being the strongest hold in vertebral bodies? I mean, reasons that you can highlight for reducing popularity of this particular technique.
Yeah, actually, if you see, it is little demanding in the sense people are little scared about the vertebral artery, and that is quite nearby. And as Dr. Upendra very nicely mentioned, that lateral cortex is actually thin as compared to the medial cortex. So chances of perforation is very high. And, if you perforate, then if the angulation is not proper, so in that case, there may be actually rupture of the vertebral artery, injury to the vertebral artery. So that is the one thing which is, important why the people have not used. And moreover, for other etiologies, the lateral mass has, served the purpose. So people are used to use it is safer than the, the pedicular screw. So people have used that. I have one more reason to quote here. So in a degenerative spine, where sometimes there are significant, compression anteriorly also. sometimes in degenerative pathology or tubercular pathology. If you have used posterior pedicular screw, then it might come in the way of your anterior reconstruction. So this is the another reason so that one tries to put only the lateral mass. So otherwise, as Upendran mentioned, that more you use, more familiar you will become. And I think this should be one of the
all 3 points are absolutely pertinent. Taking word from Upendra forward, that pre-operative planning, following strict and meticulous technique, being absolutely ready to deal with the situation that may come across. Vertebral artery injury is one very common problem that can come due to lateral wall perforation. Also, one must understand that anteriorly, if you are put in a screw, you may not be able to do a corpectomy at a later date. And of course, lateral mass still remains one of the dependable ways of fixing subaxial spine there. Dr. Mihir, how do you think that we can move in from lateral masses to cervical pedicle screw, apart from preoperative planning and meticulous technique? Is there anything that we should consider, and gradually, or the learning curve can be flattened when we start thinking from lateral mass over to pedicle screws?
No, I think the most important thing to understand here is that the freehand technique is, in fact, it's got a very high chance of failure, and the learning curve can be disastrous, in the sense the patient is at risk to life in this. So unless you are technology dependent, that means you have an O-arm or you have a navigation, you have robotics, which can guide you with a very, very small amount of precision. That means ranging in a few millimeters, which can guide most of these screws. I don't see any way of these screws becoming very popular apart from a few people who can still attempt to do it.
Right. Upendra, what made you start thinking? Is it the popularity in the West or in the Asia Pacific region of the pedicle screws in cervical spine, or is it genuinely the strong hold was needed in some cases? What prompted you to start doing pedicle screws? Because lateral mass screws are extremely dependable, for that matter. I think Ayush and all of us, Dr. Srivastava also says, they are not only extremely dependable, sometimes they are the matter of choice for us rather than pedicle. So what prompts you that no, pedicle screw is definitely the implant of choice and lateral mass is not something that I should be doing?
Yeah, basically, even intending to use any cervical pedicle screws changed when I went to Dr. Abumi. I was there probably for 3 to 4 weeks. And not only in the Abumi Institute, I traveled around 4 or 5 places in Japan. And I was surprised to see that, all the there were using cervical pedicle screws as their first choice of implantation in posterior instrumentation.
And why should we?
Yeah, exactly. So when I asked them, so it is the comfort level. So either what I thought was what they were doing was wrong, or what the Western people are telling is wrong. So either one must be something we are missing there. When we came back and started doing the cervical screws, once we started attempting the cervical screws and we got a hold of it, the safety concerns were the stability you got significant, and we started it routinely, get more
Okay. So enhanced stability is one part of it. Kshitij, quick comment. Why should we think about pedicle screws? Yeah, Kshitij, over to you. Kshitij.
Quickly, 2 points. To learn the technique, you need to try it on. First, you need to see a master, like Upendra went to Abumi. Second, you need to do it on cadaver. Third, probably, I don't think you can directly try anything with navigation first. That's one thing. Second thing, cervical pedicle screws will be useful in certain situations, but unless you are comfortable with the routine easier ones, you will never use it in cases where you can make a big difference. Like, there is a difference between doing an anterior posterior surgery for a post laminectomy kyphosis versus Abumi doing it everything posterior, or say doing surgery for a cervical deformity, or if your cervicothoracic deformity is going into the cervical spine and you are doing a major correction, something like that. So in a difficult situation, you need to have that armamentarium in you.
The question is very specific. Yes, of course, it is very true that.
But for routine cases, I don't think it would make a difference.
No. Yeah. I understand
all this, what
Dr. Srivastava said, what Dr. Naresh said. It's a wonderful tool to use. My question is, do lateral masses fail often, making pedicle screws as our primary choice, if not today, maybe in future? Do lateral mass screws fail often?
No. It depends on the pathology. It depends on the pathology.
Yeah, Dr.
Can
Srivastava.
can I make a comment here?
Quickly, last one before we move on to the next
So,
session. Dr. Mihir, your slides can pull up, please.
Yeah, for deformity correction, this is very useful, and there is a tip. Tip is that you make a burr hole there, use your probe and go in the body area, and then you tap it. Tap it from 2.5, 2.7 and 3, and most of the time you will be able to go inside. So that is the one useful tip that we usually use. Very thin diameter tap and gradually increase the hole, and then most of the time you will not perforate.
Right now, Dr. Mihir, we are done with this your session. Can you pull up your slides while you speak on? Can you pull up your slides? So, subaxial cervical spine fixation still remains one of the most controversial things to do. What is the best thing to do versus what is the most apt thing to do? It's still there is a balance hanging between Upendra on one side, promoting one of the most stable anchors in the vertebral body, probably required more often in patients with cervical deformity and complex case scenarios. However, the challenges by cervical pedicle screw, both in surgical technique, have to be overcome by a gradual and a steep learning curve. So one must learn this, keep ready in the armamentarium. Cervical pedicle screws are extremely handy, and in some cases they are the implants of choice, anchor fixation points of choice. However, for other cases, meticulous planning and bicortical anchor purchase with lateral mass screws will often suffice, particularly in simpler cases where deformity is not a major concern and where mechanical forces are in favor of you. So with this subaxial cervical spine fixation, lateral mass technique, and cervical pedicle screw technique, we are going to be coming back to both our speakers, and also Naresh Babu is going to speak about the problems in subaxial cervical spine fixation. We move on little higher in craniovertebral junction, and who else but Dr. Mihir Bapat to introduce us with C1 C2 fixation. Dr. Mihir Bapat.
Thank you, Vishal. Thank you, ASSI, for giving me this opportunity. Am I heard clearly?
Yes, clearly.
Okay. So my task is to speak about the C1 lateral mass screws and the C2 screw options. The destruction of the C1 C2 joint can be either rapid, as in infections, trauma, rheumatoid arthritis, or it can be very, very slow, as in congenital dislocations, where there is a slow creep and the soft tissues and the bone keeps remodeling, trying to gain stability around this slow creep. So as the C1 spacer becomes ineffective, or when the C1 C2 joint starts getting dysmorphic, the cranium starts settling down on the C1 C2 into a state of kyphosis, and this compresses the cervicomedullary junction. Now, these are the cases that present to us, and we need to solve these problems. So the first thing that we do is to apply a traction under anesthesia. So what the traction gives us is an estimate of how much of these vertical dislocations or horizontal dislocations can be reduced with a traction force. However, the aim of the surgery is to maintain this reduction with a strong C1 C2 fixation and the joint manipulation if required. So the main aim of the surgery is to realign. So as most of our Indian authors now believe that none of these dislocations are truly irreducible, they are rigid, and it is possible to realign them either completely or partially. And the aim is to distract the C1 C2 joint, put a bone graft or a spacer there, fix the C1 C2 complex, and reduce the various components of the deformity. One of the techniques that is proposed is to sacrifice the C2 ganglion so that you get a panoramic view of the joint here. However, one has to ensure that you coagulate the epidural plexus well so that there is no unnecessary bleeding. It can range up to a liter, liter and a half. So by using strong holds on a C1 C2 joint, it is easily possible to reduce a deformity once you have a control on the C1 C2 joint. So what is the advantage of using the C1 C2? The C1 lateral mass is like a pillar of bone. It's the strongest bone in the craniovertebral complex. It is almost constant in its anatomy. It provides the best purchase for a screw and a leeway to put the screws in different directions. when coupled with a C2 pedicle screw, par screw, or a laminar screw, you can manipulate your 7C2 joint quite well. So as you can see here, it's a big mass of bone. Once you have docked on the lateral mass, your cord is in the middle, you are safe in the safe zone, and you can angle the screw the way you want it. So the only thing that comes in the way is a very, very tenacious epidural plexus that needs to be contained. Now, you can see that that's the posterior arch of the C1. Once you go about 1.52 centimeters away from the midline, the flattened posterior arch becomes spindle shaped, and just below that spindle shape, if you dissect subperiosteally, you come to the C1 lateral mass. One assistant can safely pull down your epidural plexus. He has to be a knowledgeable assistant, of course. And as you dissect around it, you can actually define your C1 lateral mass. You can burr the inferior edge of your posterior arch to give you an access. Then you can place a sort of a self-retaining sleeve there, and then drill through the sleeve and straight away enter your C1 lateral mass in a stepwise manner. If you just follow the inclination of your posterior arch, you are invariably correct. Don't try to angle caudally. You should go along the arch of the posterior lamina of the C1. And as you go through, you get a bicorticular give way. Don't drill through and through because there's the vascular structures in front. Be very careful getting a bicortical hold. And you have to put a screw that stops short of your anterior tubercle of the C1. So this is the way the bilateral C1 screws are going to go. And then you couple them with a par screw below to give you what we call as a Goel Harms Lahiri technique. It's one of the best ways of controlling the C1C2 complex. Now, what are the contraindications for this technique? One is a dysplasia or a destruction of the C1 lateral mass, occipitalized C1 lateral mass, abnormal vertebral anatomy, or a vertebral C1 arch. Now, all these are relative contraindications. They are not true contraindications. So if you have one lateral mass destroyed, you always have the second lateral mass, which you can use. You can couple it with a posterior fixation and still get a C1C2 fixation in place. Abnormal vertebral artery. Now, this is one patient where the patient presented a 9-year-old child with stroke and ataxia. She had anomalies of bilateral vertebral arteries. On the right side, there were multiple aberrant vertebral arteries. On the left side, there was a full trunk of the vertebral artery which was crossing the C1 lateral mass in zone 2. So this may be one of the true contraindications of using a C1 lateral mass. So when they studied about 2,700 cases of normal individuals with an MRI, the vertebral artery anomaly was found in about 5% of the people. However, when you have an abnormal C1C2 complex, that is an occipitalized C1, the vertebral artery anomaly is present in 100%. Luckily, most of them are above the C1 arch, that is in zone 3. And the incidence below the C1 arch is about 5 to 15%. And this is what you must anticipate when you put a C1 lateral mass or a C2 screw. Now, when you are faced with an abnormal anatomy, just avoid putting the screw. Use the occiput and the subaxial spine if possible. Put a screw on the non-dominant side. That means if there is an aplastic artery on one side, use that because the other side may be dominant. When you are faced with a bleed, avoid temptation of putting the screw to get away with it because you may damage the vertebral artery further. Try to achieve a tamponade. Finish the fixation on the other side, which should be essentially non-screw in the C1C2, and refer the patient to interventional radiology just to see what type of damage has been done. So the other contraindication for a C1 lateral mass screw is when the C1 starts getting more and more vertical into a spondyloptosis, then putting a screw may cut out into the OC1 complex. But most of these cases are occipitalized, and you can use that mass as a fixation of the OC1 complex. So these are all relative contraindications. Now, when it comes to C2 par screws, you have to ensure that the C2 parts is of adequate thickness, and it should be at least 4 millimeters to put a 3.5 millimeter screw by the freehand technique. Once you have drilled a hole at just above the C2-3 joint, uh, instead of using a burr or a drill, what you can do is just introduce a blunt toucher into the cancellous bone as far as it can reach, and then you can put a screw over it. So it's the easiest screw to put in the C1 C2 complex. However, when the vertebral artery is high riding and the cone of insertion narrows down, you require precision tools, which Vishal will cover later on. However, you can put a shorter screw which stops short of your vertebral artery foramen. This you have to measure in a preoperative CT scan, and you can supplement this screw with a C3 lateral mass screw. So when you use transarticular screws in high riding vertebral arteries, you have to use precision tools because your margin for error is very, very narrow. Vishal will cover that in his lecture. Now, when you insert a C2 part screw and you have an adequate cone, all you have got to do is define the medial border of your central canal. You know where the vertebral artery foramen is. You expose the whole pars, you drill the opening, and you put a screw straight away. So it's as easy as that. When it comes to a high riding or a medially encroaching vertebral artery, you put a shorter screw and you supplement this screw with a C3 lateral mass screw. So that's one of the safest fixations of the C2 that you can do. In this case, because of severe dysplasia, the surgeon has avoided putting screw in the C2 and has used C3, C4, and the occiput. So this is one way of salvaging the situation. The other way is to use the C2 laminar screws. You have a good thick lamina of the C2, which is available for putting screws, and you can put two screws crossing each other in the C2 lamina and get a good purchase, which can align with your C1 lateral mass screws. So you have multiple options. You have authors like Kshitij, Srivastav, Lahiri, Goel. They come in so many options of putting different kinds of fixation techniques for the occipitocervical complex. That this is a dynamically evolving field with lots of improvisations, some with Vishal is going to talk about in his talk later on. So I think this clarifies the freehand technique of C1, C2 fixations, and I hand it over to Vishal. Thank you.
Thank you so much, Dr. Mihir. C1, C2 has always been a matter of challenge to discuss upon, and various options are open now. C1 lateral mass going straight down, laterally angulated 10 degrees, medially angulated 10 degrees are all things that can really help you to anchor it. C2, the options are far more plenty. You can use a C2 par screw, you can use a C2 isthmus screw, you can angulate it further medially to put in a C2 pedicle screw, and if there is dysplasia or vertebral artery anomaly, you can safely use a C2 laminar screw. Now, Mir, what is your preference in a normal, irreducible, non-dysplastic C1, C2 fixation?
If it's an irreducible dislocation, like I said, there is nothing called as irreducible anymore. So the aim is to open the C1, C2 joint. If possible, try to preserve the C2 ganglion, achieve adequate hemostasis, open the C1, C2 joint, distract it, use a C1 lateral mass screw, a C2 par screw, and control the C1, C2 joint reduction, which can be safely achieved. Nowadays, we use reduction screws in the C1.
Right. Umesh, you're going to be talking to us about vertebral artery anatomy. Anything in specific at this point, like a pre-operative planning measure that all the delegates who are listening and attempting to do a C1, C2, they must do as a pre-operative planning measure? Mihir mentioned about reading the bony anatomy. Anything in specific, what more they should see about soft tissue anatomy, or they must see the vertebral artery, or anything specific they should look for?
Yes, Vishal. In the absence of a bony abnormality of the cervical of the craniovertebral junction, I think an MRI is sufficient enough to give us a good anatomy of the vertebral artery. We can actually trace the vertebral artery in all the in all the planes, that is the axial, sagittal, as well as the coronal MRI sequences, and we can make sure that even looking at the size of the vertebral artery, we can even assume, though it is not very affirmative, we can also assume which side is dominant or whether it is a codominant vertebral posterior circulation. However, in the presence of a bony abnormality, the vertebral artery anatomy may not be clearly discernible by an MRI alone. And in the presence of a congenital bony abnormality, an atlantoaxial dislocation, or basilar invagination, so it is always advisable to do a CT angiogram in order to actually identify the vertebral anatomy, as well as to identify get more details about the bony anatomy, as well as to identify the vertebral artery anomaly or any kind of a vertebral artery course that has been altered due to the bony abnormality in these particular situations.
Right, right. So it's very important. Mihir highlighted about noticing the anatomy of bony trajectory of the screw to get the right entry point and planning the trajectory both in C1 and C2. It's extremely important because the bony variations are plenty. It can range from 3 mm to 4.6 mm in terms of diameter of the pars, and the thickness of the C1 lateral mass may also vary. Vertebral artery anomalies can range from 5% to 27% depending upon the bony anomalies present. And if there's any single bony anomaly, up to 25% of patient vertebral artery anomalies can be found, which can be treacherous. Dr. Srivastav, you're going to be talking to us and telling us about the fusion mechanisms in all the subaxial and CV junctions. Anything in specific, like while doing a C1, C2 fusion, that we should do to achieve good biological fusion? What is it that we should pay attention to while doing the surgery?
Yeah, so in that case, C1, C2 joint, as Mihir rightly mentioned, you have to put the puka and just rotate, or even your periosteum. The cartilage has to be taken out. You must decorticate. And in cases where you want to bring, suppose in case of basilar invagination, either put a cortical, cancelocortical strut there, or you can put a case there. So fusion is achieved. So basically the osseous fusion is very important in this area, and C1, C2 lateral joint is very good. So there you can stack the bone graft and this is going to fuse. Moreover, if you have a screw fixation through that, it is going to fuse definitely. There is no doubt about that.
Right, right. And Dr. Mihir, one quick question. You mentioned about 1 to 1.5 liter blood loss. How do you ensure that there is no bleeding? We have seen surgeons who are least bothered about bleeding, and we have seen surgeons like you and Chitij who are extremely meticulous in hemostasis. How do we ensure there is minimum possible blood loss while you're doing exposure for CV junction? Can you please elaborate your steps?
So I think you need to work on both sides. Like I said, you need to trace the C1 arch laterally and then work subperiosteally to pull down the epidural plexus downwards. And from below, you walk along the C2 pars to enter the joint. Now you are subperiosteal. So if you want to preserve the C2 ganglion, you have to stay subperiosteal, use a bipolar cautery whenever it is required, and keep coagulating as you approach the joint from top as well as the bottom. And then you get a good exposure where you can put your C1 lateral mass and put your pass through. The other way is to sacrifice your C2 ganglion, use lots of bipolar, and just coagulate every ounce of epidural plexus that you can see. Just burn it off.
Right, right. Thank you, Dr. Mihir. I'm going to just show a different perspective of C1, C2 fusion. Like Dr. Mihir just highlighted, there is nothing called irreducible C1, C2 fusions, and I would probably try to emphasize upon the very fact that every subluxated or dislocated C1, C2 joint can be fixed by a transarticular screw, which is, to my hands, the gold standard of C1, C2 fusion. What is transarticular screw fusion? Transarticular screw fixation is a screw fixation which runs via from C2 entry point lamina through the C2 pars, going through the isthmus, passing from C2 joint into the C1 joint, entering and ending into the C1 lateral mass. So that's the kind of trajectory. So a screw passing from C2 going all the way into C1 and engaging three-dimensional fixation points in an oblique manner and fixing the C1, C2 joint to give the absolute rigidity. And this is what transarticular screw is all about. And this is something that is useful in almost every pathology which is CV junction related, and it is reducible. Now, why transarticular screw and why not C1C2 segmental? I would say that it's still the gold standard of C1C2 fixation, gives the absolute stability, and I would say this is the only technique which gives you 100% fusion rate. In fact, all our papers we have studied that almost always there is not a single paper where transarticular screw loosening or implant failure has been reported or implant loosening has been mentioned in transarticular screw. In our study also, within 9 months, 100% fusion rate has been achieved, and this still continues to be there. That transarticular screw gives you 100% fusion rate, and that's why always whenever you fuse C1 C2, go for a transarticular screw fixation. How do we do it? I think the 90% of transarticular screw is done outside the patient. It is all about planning and the need of all the facts that whether Umesh mentioned, Mihir mentioned, or for that matter Upendra mentioned, and also Ayush emphasized that pre-operative planning, not only of your entry point, of your trajectory, of anomalous vertebral artery, bony conditions of the pars and isthmus, the diameter of the pars, all these have to be evaluated pre-operatively, and every single investigation would come handy to you, be it in terms of dynamic x-rays, be it in terms of doing a CT scan, thin fine cuts there, or even for that matter CT angiography. In first 50 cases at least, I would recommend that always try to do these investigations to find out every single detail about the bony and soft tissue anomalies that can coexist while you're planning to do a transarticular screw. And once you have planned this, then I think execution of this particular plan is only 10% of what you want to achieve in this particular patient. So let's see this in detail. What is planning all about? Planning is all about checking whether there is a feasibility of transarticular screw. And believe me, if you follow these basic steps, the chances of you having problems with transarticular screw is almost nil. And that's my guarantee to it. That check whether feasibility of transarticular screw is there or not. What is the exact trajectory of transarticular screw that I'm going to get? It may be tailor-made, it's not fixed. Magrel and Neo did mention about a fixed trajectory and a fixed entry point, but in our papers in last decade, we have come up with 7 papers. Every time we have emphasized this, that the exit point is fixed. However, the trajectory and the entry point has to be tailor-made and has to be retrospectively projected based on the exit point and the thickness of the parts. And you can do transarticular even in a high riding vertebral artery. And that's why planning the trajectory, which has to be tailor-made, is absolutely important in all our patients. And this will also decide about the positioning of your screw and position of the patient. And of course, be always ready with the inventory of the implant. You cannot have only 3.2 or 3.5 or 4.2 screws in your hand. You always got to have almost every diameter of the screw. And to my despite, I mean, I got stuck a couple of times when I didn't have a 2.7 narrow millimeter cannulated screw. And now I make it a point that whenever we do a transarticular screw, always keep not only sublaminar wires ready, because sometimes you may not be able to do it. And sometimes I would keep Herbert screws, which are like 2.3 millimeter cannulated screws, like in kids of 3 years old. These come really handy where the diameter of the pars is 3 millimeter. So always have all this wide inventory in your hand, because intraoperative, no matter how much you plan pre-operatively, sometimes you may come across surprises, and it's your implant inventory that can really help you and make you a handy and good outcome. Intraoperatively, Mihir just highlighted upon some of the surgical steps, and this is something that cannot be overemphasized, that C1, C2 surgery is all about a soft tissue surgery. It's about dissection techniques. So on one hand, you plan your entry point, your trajectory, your exit point, the screw diameter. All these are mechanical works to be done on bone. However, the success of the surgery depends on how good you are dissecting the CV junction area, and that purely depends how subperiosteally, how calmly you dissect on the C2 pars area, how you expose the C1 posterior arch without actually going all the way down lateral to the vertebral arteries. And this is something that will also help you give wings to do all these surgeries in a minimal invasive percutaneous manner also. We are going to be discuss some of these cases in coming slides. So what do I mean by surgical feasibility? The primary rule of transarticular screw is that you got to have a reducible atlantoaxial dislocation. Transarticular screw is contraindicated in a patient where you are not able to achieve reduction. And like Mihir said, I thoroughly believe in this fact that there is nothing called irreducible atlantoaxial dislocation unless until there is a bony contracture, there is a bony block or a dysplastic C1, C2 joint there. If there is no dysplasia of the bony elements in C1, C2, and there is no bony contracture, I think all the irreducible AADs are reducible ones. You can either reduce them intraoperatively. In fact, 30% of times, the moment you position them, the moment you give them anesthesia, they will just reduce. And all these so-called irreducible atlantoaxial dislocations can easily be reduced either by positioning or by certain maneuvers. I'll highlight some of these. But the basic fact is that transarticular screw is possible only when you are sure that you'll be able to achieve complete or near complete complete reduction of C1 over C2. Unless until you achieve this, transarticular screw is not recommended. Particularly in malunion of odontoid fractures, should not be doing it. High riding vertebral artery, there was last decade when it was said to be a contraindication, but now today I think a high riding vertebral artery by definition doesn't mean a contraindication if the pars diameter is more than 3 millimeters. And I would say that transarticular screw is now a contraindication only when the pars diameter is less than 3 millimeter, even in a patient with normal vertebral artery. And so that's why I would say that rather than looking at the high riding vertebral artery, look at the minimum pars diameter, and this term called MPD, minimum pars diameter, is something that we must pay more attention to. Presence of thoracic kyphosis, again, you will not be able to get a good trajectory, and that's why all these things have to be ruled out to check if there is a feasibility of doing a transarticular screw or not. And this is what I mean, that the minimum pars diameter, if it is more than 3 millimeters, even in an anomalous vertebral artery, you'll easily be able to get a good transarticular screw, because not only is there elastic expansion of the pars, but also a 3 millimeter screw can easily be passed to a 3 millimeter pars there. And that's why even in a patient with high riding vertebral artery, if you have, not that I recommend you all should do a transarticular screw in a high riding vertebral artery, but if it has to be done, it is surely possible. There are cases we have done in our past, more than 20 now in our series, that if the pars diameter, minimum pars diameter is more than 3 millimeters, you can surely safely pass in a transarticular screw from C2 to C1, achieve a good fusion there. Now, this is the second and the most important slide. There is one slide you want to carry home from here about planning of the screw, which is pre-operatively happening, is understand this fact that once you have known that it's a reducible C1, C2 dislocation, you have a pars diameter of 3 millimeter or more, that means a transarticular screw is possible. Now, what you need to fix is that the exit point has to be fixed. It has always got to be in zone 1 and zone 2. So the tip of the screw which it exits, you should always understand that on a C-arm image, your tip of the screw has to come here. It has to end here, and it has to end here. It has to end here. And this end point is fixed in almost all cases. It cannot be changed, because if your end point comes in zone 3 and zone 4, that means you have already perforated the vertebral artery foramen, and the chances of you having a VA injury is very high, or a misplaced screw is very high. And that's why understand that your exit point is fixed in all cases. And the trajectory and entry point is only a retrograde projection. So this is something that has to be tailor-made. You have to get your trajectory retrograde from the exit point, traveling on the bone pars which is actually felt during your surgical exposure, and wherever this exit point via this trajectory falls on the lamina becomes your entry point. And these two factors, which so far in Magral-Neo classification and their papers, they have always mentioned a specific angulation, they have always mentioned a specific entry point. To me, I feel there is no specific entry point, and there is no specific angulation or trajectory that one must follow. It is always tailor-made, and it is so variable that every individual, it's a different thing. However, one thing that must be kept fixed in all patients is that your exit point of the screw, your tip of the screw, should go and lie in zone 1 and zone 2. And case you will be able to see that if your exit point is fixed, you are able to plan this trajectory pre-operatively. You'll be able to get a good entry point, and that's something that you can easily do it even in half an hour's time, and you'll be able to get a good trajectory there. Now, positioning plays an extremely important role. Once you're ruled out there is no thoracic kyphosis, it is the military chin tuck position where the C1 is pulled back on C2, not only getting a good reduction there, but also giving you a fairly flat CV junction area to get good screw trajectory there. And remember, like Mihir highlighted, I would again emphasize that there is nothing called irreducible C1, C2 dislocation. It is the lack of knowledge of reducing maneuvers, which we all do not either practice or don't try to dare to do them. But a thumb push either by a transoral technique on the C1 will lead to reduction, or a prone C2 spinous process push. Like in this particular case scenario, you see, if you see an irreducible one, you can either put in a wire and reduce it back, putting in pukkas and doing a C1, C2 distraction technique, or for that matter, using a mouth push technique. Like in this particular case scenario, we used a pukka to reduce it, which otherwise till preoperatively looked a completely irreducible odontoid malunion, and it became completely reducible, resulting into a transarticular fixation. This is a 7-year-old male child, otherwise looks to be a completely, even on traction in the wards, patient was just not having any mobility at desk. But the moment you put in your thumb under C-arm guidance, under anesthesia, it is completely reducible. So this is like a C1 push technique, and all this you must try. This can really save your day. It can prevent you a second surgery. It can prevent your implant stress completely, and you will really be able to do a simpler surgery rather than doing a complex surgery of anterior, posterior, or a occipital involvement. Like in a 7-year-old child with this X-ray, even on traction which is not reducing, just by the mouth push, and it completely reduces to get a transarticular screw fixation. Another patient where distraction and wiring both were used in combination, otherwise looking completely irreducible despite having a traction of 5 days in ward, and it still doesn't work, and you are able to get good reduction, allowing you to do a transarticular fixation. So what I'm trying to emphasize is that almost unless until there is a dysplastic joint, unless until there is a bony contracture, all C1, C2 subluxations are reducible, and most of them are reducible only by posterior techniques. Sometimes you may want to do an anterior release, and once you're in an anterior release, then it becomes completely feasible to do a transarticular screw fixation in them. And remember, the reduction has to be confirmed by a true lateral image where you are able to see complete width of the pars on the C-arm. You are able to see a C1 lateral mass, and the anterior arch of the C1 is seen like a point mass. And this is something that is extremely important, because unless you get this kind of imaging, your screw is going to be malplaced, and your exit and entry point both can be malplaced and give you a dodge there. Now, once you're done this, draping has to be done all the way, keeping the T1 exposed, because most of the times now it is done percutaneously, where your screws come from T1 spinous process, and the exposure is only done to get the entry point and the trajectory right there. Like in this particular case scenario, you can see that the exposure is done at C1, C2 junction, whereas the screws are coming far from the T1 area. And these are some preparations in inventory you may want to keep. I always do it under microscope guidance using a C-arm, lateral view only, no need of AP. High speed burr and cannulated drill is something that is extremely important, and be ready to deal with bleeding, because no matter how good a master you are, sometimes vertebral arteries can be really nasty, and you may really want to control that and be ready, which Umesh is going to tell us how we are going to do that. Surgical steps, very simple. You have planned it. Now is the time to execute your plan. Midline 3 centimeter incision. Almost all cases, you really don't want to do any bigger incision there. Dissection only on the lamina of C2. You do not want to expose the C1 arch at all. Surely not the superior arch of C1, particularly in kids less than 15 years. If you expose any amount of superior arch of C1 posteriorly, inadvertent C1, C2 fusions are known to happen. And if you destroy or even burn C2-3 joint, particularly in patients with rheumatoid arthritis or JRA, or in kids, C2-3 fusions inadvertently unplanned are also known to happen. And this is something that you may want to avoid your dissection, not only at the C1, C2 mid area, but also above C1 and below C2. You have to keep a dissection absolutely minimal without destroying any soft tissue there. Enter into the joint. And as I said, Mihir also highlighted that you have to actually expose it. I'm going to be showing it in the video here. So that's the midline. That's the C2 spinous process. The head is on the left, the foot is on the right, the upper part is the right side, and the lower part is left. So with the help of cautery, you use only up to the lamina. You only dissect subperiosteal up to the lamina. That's C2 on the right side, and that's the inferior part of C1 arch. That's the inferior part of C1 arch. Connecting the C1, C2 area now. And once you have reached the lateral most extent of the C2 lamina, that's the pars area. With the help of your patty and a McDonald, you just walk on the pars, and you can actually see the whole pars from the lamina going into the joint, and your patty actually goes and packs the vertebral artery. So here you can actually see that the pars here is as narrow as 3.2 millimeter, and the retrograde trajectory, the retrograde projection can easily be made that this is the retrograde projection. This is the retrograde projection, and that's where the entry point of the transarticular screw is going to be. So even in the narrowest pars, which is right in front of your eyes, you are able to see that. And on C-arm, you can see the exit point, and you can actually make a good entry point there, and you can work through. So that's how you proceed then. And then the percutaneous screw comes from the C1 lateral mass. Your drill sleeve gets, and guide wire starts coming up. And as you can see on the C-arm images, now is nothing. Your guide wire goes in, your exit point is fixed. You got an entry point and a retrograde trajectory, and your guide wire and the C-arm guidance, your screw goes in. And then between C1 and C2, there have been a mention of use of sublaminar wires under C1 arch, but we have never used it. We actually use only morcellized allograft in all our patients. We have never used a supplemental wiring, and believe me, you just don't need it. It just uses like fire. And these are just some case examples. A failed odontoid where we did a posterior transarticular screw fixation. Another case of transverse ligament, again C1, C2 fixation, small proximal fragment, again C1, C2. This is the atypical Hangman's variant, C1, C2 fixation was done. A patient with pars fracture, again C1, C2. Tuberculosis of C1, C2 joint, a narrow pars which was eroded, again transarticular screw, even in a high riding vertebral artery was done. Again, you see what the most important thing is that your exit point is fixed, and you can see the type of fusion that you achieve, not only in inflammatory or degenerative conditions, but also in patients with inflammatory arthropathies, like you see here. And this continues not only normal anatomy patient, but also in patient with dysplastic anatomy, like where pars is less than 3.5 millimeters. Also, you can do it with the help of navigation using thinner implants, like in this kid of 3 years with torticollis and rotatory C1, C2. We used a Herbert screw, and this is how the kind of fixation we got. Another 3-year-old child with torticollis, odontoid malunion, again with the use of tiny 2.7 mm screws cannulated, we got it. In patients with high riding vertebral artery, again you can get it. You can get a good trajectory if your exit point is fixed, and you can really pass on this with not only with freehand, but also with the help of navigation, which we have been using currently to do transarticular screw fixations as well. Now, this transarticular screw is very important not only in patients where C1, C2 fixation is required, but also it becomes a construct when you are doing syndromic C1, C2 junctions, which otherwise would require going all the way down to subaxial spine. With this such strong hold in there, you can use the same C1, C2 fixation or occipito-cervical fixation, stopping sharp at C2 junction without actually needing to go in the subaxial cervical spine, because your anchor at C2 is so strong there. And this is the technique that we have been following to do these OC2 fixations. And now eventually we have stopped going anything down in the subaxial spine. All our fusions stop at C2 junction there. And this technique remains the same of passing in screws. And as I mentioned, fusion in 100% of patients can actually be seen inside the joint along the trajectory of the pars. As you can see, not 1, 2, 3, but many more cases that are coming our way. Vertebral artery injury, I think Umesh is going to be talking about this. It is one of the more known complications in patients. But again, as I said, you follow certain principles of planning, and you can really be able to choose your patient well in reducible cases with no anomalous vertebral artery. In earlier cases, I would not recommend doing this in high riding vertebral arteries, and you will be able to do this with a fixed exit point, retrograde trajectory, and a tailor-made entry point is something that brings in the 100% success of transarticular screw. I would stop there and open to discussion there. Me, sir. Any questions, or while we go on to Kshitij slides come up?
Can I ask one
question?
question?
Yes, Sudhir, sir.
In some of your cases, where you have gone to the zone 1. So I have a fear of, violating the occiput C1 joint. Okay, so I think that is one thing it should be careful. That is the only thing which I would like to mention.
Yes. In fact, it's a very interesting point. But the most important thing that we must pay attention to is that your screw tip should not aim for the anterior most portion of the anterior arch. Yeah. Because we must remember the paradox that the anterior arch, the dot seen on the lateral X-ray, is far anterior to the anterior most portion of the lateral mass. So your screw should fall short of the anterior arch. In fact, it should be at least 5 millimeters short. But the zone should be zone 1 and zone 2 only. Always try to have your exit point in zone 1 and zone 2, never in zone 3 and zone 4, and try to have your screw short. If you're going in zone 1 or above, keep your screw even shorter. The beauty of this comes when you are dealing with an assimilated C1 to occipital screw. So where your C1 arch is assimilated to occiput, you can actually put the screws longer, where it just goes into the clivus as well, where you don't have to worry about OC joint, which is already fused there. So if no more questions, we can move on to Kshitij, who's going to take us further up. We started with subaxial spine lateral masses. We went on to see cervical pedicle screws. We heard Dr. Mihir Bapat about fixing C2 with various options of pars, isthmus, and C2 laminar screws. We saw C1 lateral masses screws for C1, C2 fixations. We just heard about transarticular screws. Going one step ahead, there are multiple pathologies which will require occiput to be fixed to the C spine, and how to do occipito-cervical fixation. Over to you, Kshitij.
Thank you very much for the invite. So my job is to show you the technical nuances of occipito-cervical fixation. So we'll go over some surgical anatomy first. The occipital bone has 3 nuchal lines. Supreme, which is not really in the exposure, but the main ones are the superior and the inferior nuchal line. The external occipital protuberance is the most prominent part of the bone that you can feel where the supreme and the superior lines converge, and running down from it is the midline keel. The superior nuchal line corresponds to the transverse sinus, and the external occipital protuberance, or the EOP, corresponds to the torcula, which is the confluence of the sinuses. This is a model of the patient's occiput whose surgery I'm going to show you today. You can see how the instrumentation has to stay below the superior nuchal line and below the transverse sinus. If you shine a light inside a skull, you will see that the thickest part of the occiput is at the EOP and along the midline keel. The screws ideally have to be placed in an area that corresponds to an inverted triangle whose base is just below the EOP. A bit about construct biomechanics. It is proven without a doubt that screw rod constructs are the strongest and most rigid. Which screws you use in the cervical spine is not so much of a controversy. Transarticular screws, C2 pedicle screws, or C2 laminar screws are all equivalent. However, some studies have found the C2 laminar screws not as strong as the others. At the occipital end, there are two possible configurations. Screws in the midline are stronger than those placed in the parasagittal area. To make both these constructs equivalent, you require 6 parasagittal screws, 3 on either side, whereas in the midline, 3 screws suffice. Bicortical purchase increases the pull-out strength by 50%, but at the EOP, due to thickness of the bone, a unicortical screw is equivalent to bicortical screw elsewhere. But the most important contributor to the construct stability is actually the rod diameter. A CT angiogram is must for preoperative planning. Apart from looking for the vascular anatomy, also make an attempt to look at the midline keel. Sometimes it is not in the midline like in this patient. The positioning is of utmost importance in OC fixation, and be very careful of an excessive military tuck position. You cannot have a double chin visible here like Vishal showed that picture of military tuck position. If you fix a patient in a military tuck position like this patient with a double chin that is visible, the patients will develop postoperative dysphagia and breathing difficulty. So that's not possible to do. Whenever you have to fix them, decompress them, you can do it in this position, but when you fix them, you correct the position of the head. So how do you know when the head is not in excessive flexion? You have to check the lateral X-ray after positioning. And the OC2 angle, which is the angle between the McGregor line and the C2 inferior end plate, should be lordotic. And the normal range is about 0 to 30 degrees. It should never ever be kyphotic or lesser than your preoperative angle. So always measure this angle preoperatively as well. So I'll go to the surgical video.
The surgical exposure and insertion of the cervical screws has already been done. To the right is the occiput. I am a left-handed surgeon standing on the right side of the patient. Here you can clearly see the external occipital protuberance. That is the midline keel or the crest, which will be the thickest part below the EOP. The superior nuchal line runs horizontal on both sides of the EOP. Ideally, the screws should be in an area that corresponds to this inverted triangle shown here, whose base is just below the EOP. This midline keel plate does not allow the screws in an inverted triangle configuration, but there are ones available like this that can. We cannot place this plate in reverse, as by doing that, the side connectors will be prominent underneath the scalp. Make sure that the size of the plate is appropriate such that the rod will connect easily to the cervical screws. Then mark the site of the topmost screw just underneath the EOP in the midline. Using a 3 mm burr, make an entry in the outer table of the skull. Then use a drill bit through a drill stop. The drill stop does not allow the drill bit to go beyond the measured distance. For the first pass, we have set the drill stop at 6 mm. After every pass, the hole is checked with a ball tip feeler. If the inner table is intact, the drill stop is increased by 2 mm. Generally, in the midline, we have to increase this couple of times to approximately 10 to 12 mm to break into the inner table. We recommend doing this in a stepwise manner to prevent inadvertent injury to the dura or other vital structures. If a CSF leak does occur, this can easily be stopped by bone wax or by placing a screw. If by mistake you are at the wrong location and puncture the dural sinus, similar strategy can be employed. Once inner table is drilled and a soft feel is noted by the feeler, the hole is tapped through its entire length. It is imperative that the inner table is tapped as well, because if this is not done, the screw tip will abut the inner table and strip away all the tapped threads. This will loosen the screw's purchase considerably, so take the utmost care to ensure that the hole is completely tapped. Sometimes a part of the EOP needs to be drilled away to flatten the surface so that the plate can sit flush with the bone. A curvature can also be given to the plate so that it corresponds to the curvature of the occiput. Then the keel plate with the side connectors is fixed to the skull with a 2 mm occipital screw. The side connectors need some bone wax to stay with the plate, otherwise they will fall off easily while doing this. Tighten the screw such that the plate sits in the correct orientation. Similar steps are carried out for the other screw holes. As you move caudally from the EOP, the thickness of the midline keel will gradually reduce. The screws of the midline on either side have the thinnest skull thickness in this configuration. Approximately the midline screws are somewhere between 10 and 12 mm, and on the sides they are about 8 or 6 mm. If we have used a 12 mm screw at the top, this one is either going to be a 10 or a 12. Again, ensure that the screw holes are tapped completely to the inner table. If the screw does not grab the bone or does not advance, do not push it in with force. This never works and the screw threads that you have tapped will strip away. Instead, gently remove the screw and tap the hole again. Typically in the midline, the skull is so thick that you will feel the screw grabbing the outer table and the inner table separately. When the screws are tightened, they should not keep rotating in place, what in orthopedic lingo we call a GFR screw. They have to grab the inner table and stop rotating with a torque like this. For the two side screws, I like to converge the trajectory of the screw like this towards the midline crest. The rest of the steps are the same. The screw here are smaller and you might just drill one cortex and reach a soft endpoint. We have used the 8 mm screws in this case. Finally, tighten all the screws so that the plate sits flush on the bone surface. Next, to contour the rods, I like to use a malleable aluminum rod. A significant angular bend is necessary at the OC junction. These rods are soft enough that they can be pushed into the screw to get a template for bending the rods. They can be sized accurately as well, like this. The final rod is contoured with in situ benders and it needs to be shaped exactly like the aluminum rod template. This avoids trial and error, as repeatedly bending and unbending the main rod will weaken its strength and notch it considerably. Now that the rods are ready, I like to decorticate the C1-C2 joints with a curette. This is the last step before the rods are locked in, as this area can bleed considerably when disturbed like this. The joints are crucial area where the fusion takes place. Hence this area needs meticulous attention. Autograft bone from the iliac crest is packed into the joint. If reduction of basilar invagination is required, which is not the case here, then the joint can be distracted using Goel's cages. Finally, the rods are locked in place. In this patient, the reduction was achieved with position and traction, hence much manipulation over the rods was not necessary. If the rods are under-contoured, then by cantilevering the rod to the occiput, one can push the odontoid forward. In addition, the alignment can be changed by compression and distraction over the rods. While tightening the rods, either use a rod holder to provide counter torque or an anti-torque device. This prevents stressing of the screws. The final step is the decortication of posterior bone surface and placing onlay bone graft over it. Thank you very much for watching.
That was about the surgical technique. If you want to do a reduction maneuver on those rods, you can do a compression distraction like this over those rods, or if, Abumi has described a technique to correct dislocations using an under-contoured rod. So all those maneuvers can be done on these rods. Coming to salvage, if your occipito-cervical fixation fails, or if the neurosurgeon has done a very big suboccipital craniectomy, you have nowhere to place the plate, then this area is one area where you can put the screw, the occipital condyle. I've never done it before. It seems quite a challenging screw, and I don't think you can really do this screw freehand quite easily. So what you have to do is basically follow the margin of the foramen magnum, reach where the medial border of the occipital condyle is. From there, walk over the occipital condyle until you see emissary vein, the posterior occipital emissary vein. And that's your lateral extent of dissection. And the entry point is about 4 or 5 millimeters medial to the medial margin of the occipital condyle, and about 2 millimeters above the occipital joint or the inferior facet. And the trajectory is inwards. You can imagine where all these, you have the vertebral artery here, you have the internal carotid artery here, this is the hypoglossal canal, the hypoglossal nerve is here. So overall, this is quite a challenging thing to do, and I would say that without attempting this in cadavers first, or having some kind of computer navigation to do this in a difficult situation is a hard thing. It's not caught on very well till now. The other techniques, probably an easier way to get that. I don't know, my slide is not in my, sorry.
Yeah, Kshitij, maybe we can just move on and summarize this here.
Yes. Take a minute. Yeah. So the other one is an Atlanta-occipital transarticular screw. Again, instead of putting a C1 lateral mass screw, you just direct the trajectory quite high up. Again, this requires quite a bit of understanding the anatomy in this region and avoiding all those important things nearby. Wiring was the old technique. It requires a lot of multiple fixations, and is not really the first choice at present for this kind of fixation. For very young children, less than 2, 1 or 1.5 years old, maybe something like this can be attempted with ribs and Marcelin tapes, but eventually you have to put these patients in a halo, post-op halo immobilization. So that's it. I can stop here.
Yeah. Thank you so much, Kshitij. It was wonderful. Any questions so far? Dr. Gautam has it, or anyone in the panel? So we all must remember that all these instrumentation techniques are done only with one single goal, that is fusion. Dr. Srivastava, while your slides can come up about fusion in craniovertebral junction and fusion in subaxial spine, tips and tricks, how do we win the race of biology versus metallurgy? Is it the implant that gives fusion, or is it the surgeon that brings in fusion? Who other than Dr. Srivastava to tell us about the basics of fusion tips and tricks in CV junction and subaxial fusions? Dr. Srivastava.
Can you unshare, Vishal?
Yes, sir, it is unshared, sir. You can share your screen now.
Okay, just trying. Are you able to see it?
Yes, sir. Yeah. You'll want to go on slideshow mode.
So, thanks ASSI for giving me this opportunity. I'm going to talk upon the fusion in craniovertebral junction. tips and tricks. So basically, I will not be dealing with any fixation part because this has been very nicely covered by Dr. Vishal, Mihir, and Dr. Chitis. So I'm going to talk on the tips and tricks in this. So here, in occipital-cervical fusion, what are the important tips? Now, it is the preparedness for the reality. It is an extremely mobile region, and usually because of this region, we don't want to extend our fixation to the occiput because it actually immobilizes that very vital area. So unless there is a real need, and that need may be destruction of the C1, C2 lateral region where you cannot put an implant, or already there is a hospitalization of the atlas, and there is no point in putting the screw in the atlas, you can go directly to the occipital area. Or the other reason for failing or going into non-union in this area is that there are a lot of ligaments there. The bony elements are not there as much as it is there in confluent in the subaxial area. So there is a poor bridging bone and there are shallow joint. If you see, the C1 is just like a small bushing in this area. And that is the reason the non-union chance in occipito-cervical fusion is very high. Now, if you go through these area, you find that proximally there is a cortical bone which is there in the occiput. So you have to bury it to make it good osteogenic bed. So this is extremely important. Unless you do this and just put the bone graft, that is not going to unite. There should be a bridging graft. Don't just put the pieces there because that is not going to taken up by the occipital area, which is mainly the cortical. So you must use the bridging cancellous and cortico-cancellous graft. And here I am going to stress throughout my talk about the stability of the graft. Now you must try to stabilize the graft also. You have already done the good fixation, but if you don't provide stability of this graft, then this might go into non-union. So to increase the fusion rate in this occipito-cervical fusion, you must stabilize the graft. Now, this is the osteogenic bed which you are going to prepare, and this is the area which is commonly used. You can use the atlantoaxial joint and occipital C1 joint. Here you can use the posterior part of the lamina. This is also available for making the bed. Then you can have a C1, C2 joint and the lamina of C2. So these are the area one has to make it work and make it very osteogenic so that there should be punctate bleeding in this area. Now the bone graft which has been used from the fibula till the autograft, and sometime you can mix the allo and autograft. The fibula has been used long as way back 1920, and then the people started using allograft mixed with the autogenous graft and then the thinned out graft, and the non-union rate in those situations were almost 40%. Now I will just show you an example. Here this onlay graft has been tied with the wire, and you can see here people used to immobilize the patient in the halo. They used to use the bone cement, but still the non-union rate was very high. I'm just going to show a case. This was an 8-year-old male. Here had C1, C2 cox, extensive destruction. Here you can see there is a basilar invagination also in this case. And this patient has significant neurological deficit. So the operative plan was to have occipito-cervical fixation and fusion. And here, since one side it is already gone, so I have put the laminar screw. This was the fixation which we achieved. And then here I will just show you the video. Here the burying is extremely important. You must have a punctate bleeding in the C1, C2 area, and also in the occipital area. Take out all the soft tissue, bury it nicely. So in this triangular area, I am burying the occiput, and just assure that you have punctate bleeding in that area. So then only it will be called as a good osteogenic bed. Now here you will realize, no, I will just go one back. No, because I want to show this. Apart from midline, you have to also put graft in the lateral gutter. Now here I usually extend till C3 because C1 is significantly destroyed. So between this C2 and C3 joint, you have to put graft inside, pack these cancellous pieces here, and pack it so much so that this lateral part of the graft is going to touch the medially put these long slivers of the cancellous graft. So you have to take extra care and extra pain to put graft nicely, and after you put all these cancellous chip, you try to press it with your right angle punch like thing, so it gets stabilized in that area. And if you try to move with your finger, you will find that it is not moving, it is very stable. So try to bridge this, and this is going to help you in fusion. Now I'll just go ahead. Now here I'm going to show how I shape my graft. The triangular piece which I have taken out, I convert it like a Y-shaped. I'm going to make two holes, and through which I'll be passing the suture, and that will be actually tied by the thread. Now here I will show how to do that. So take a vicryl suture. From the right side first, you insert. I have a hold on the right side of the rod, and the suture should be lying in the upper part of the rod. Then insert through the graft, which is almost like a Y shape. This Y shape is going to be there on the lamina of C2. So since we wish to put the cancellous surface posteriorly, you try to pass the needle in that fashion that cancellous surface remains up. So passing from cortical to cancellous is easier, but passing from the cancellous to cortical is a little difficult, and you have to search because it gets collapsed. So here I have passed it. Then keep it loose lying inferiorly. Now you insert this needle on the left side of the rod. Now here again, you also try to use the medium sized needle, not the very large like this, because you should not puncture the soft tissue which is lying on the lateral side. Otherwise, it might lead to unnecessary bleeding. So try to pass it safely and try to take it out. And then once you have taken it out, then you reposition this shaped graft, which will be bridging the occiput and the C1, C2 area. Now this part is extremely important. I'm going to show this, and this we must not avoid, we must do it. So I'm going to tie this. You can see here again, my vicryl is lying in the upper part of the rod. If you tie in the lower part, if it slips, it will become loose. So tighten it nicely, and it becomes very, very stable. So you are pretty sure that you have stabilized this bridging graft. So this is extremely important. Now this was the fixation and fusion. Now in pediatric age group patients, sometime if there is a significant destruction, now you can see in this case, I have used hard steel rectangle and sublaminar wire. Now why to show this slide? Here I just want to show you how to stabilize the graft here. I have turned inside these cut end of the wire, and that has given a very good stability in this case. Now you can have different congenital anomaly where you wish to go to the occiput, and I will be just showing one case. This patient was significantly neurological compromised. He was in bed almost for 8 months, and this was the picture where you can see the C2 is also actually separated. So you see here the Klippel-Fish syndrome. There is a fusion of the posterior arch of all these vertebrae. So first I did the transarticular screw fixation to have a hold of C1 and C2, and then put the lateral mass screw, then went till the occiput, and then decompression was done nicely. So here I have taken about the margin of the occiput. So margin of the occiput has been taken out, and till lower down we have nicely decompressed it. So the neural structure is absolutely free. And then I have again put this long graft where I have stabilized the graft by actually tying it. So this is very essential in occipitocervical area. You must have a bridging graft and you must give stability to this graft, though you have stabilized the area. But if you just keep a loose graft there, and once you suture and there is a movement in the soft tissue area, that will come down because it is high riding, it is going up. So this is extremely important. You can see that bridging graft here posteriorly, just behind the rod, you are able to see that graft, and this patient healed very nicely. So what is the conclusion? Proper osteogenic bed preparation in occiput and atlantoaxial region, laying down and stable bridging of good quality cancellous or corticocancellous graft almost ensure sound occipito-cervical fusion. I thank you very much for your kind attention.
Thank you so much, Dr. Srivastava. May I now call upon Umesh to please come up and bring out his slides while Dr. Srivastava unshares his screen. Umesh, maybe you can share with us. Vertebral artery injury and vertebral artery anatomy is the single most common factor which is responsible for 99% fear and probably 1% of disastrous complications that can happen in CV junction. Maybe Umesh can help us to overcome our fear, 99% of it, and 100% of our complications related to vertebral artery injury. Umesh, over to you.
Yeah. Thank you, Vishal. Thank you, Dr. Zaveri and ASSI for this opportunity. And as the topic has already been told, I'm going to talk on vertebral artery injuries predominantly at CV junction, because subaxial cervical spine vertebral artery injuries are relatively less common, and only nowadays, with the advent of cervical pedicle screws and more usage in cervical pedicle screws, these injuries are often encountered in the subaxial cervical spine when doing posterior surgeries. Of course, still anterior cervical discectomies and fusions still account for a significant proportion of vertebral artery injuries, which we will not be covering in this particular topic. Of course, one important thing that we have to understand, apart from the surgical techniques of inserting screws, is the anatomy of the vertebral artery at the cervical vertebral junction. And it is very important to understand that the vertebral artery at the CV junction has been divided into three portions. Apart from the vertebral artery that starting from its origin from the brachiocephalic trunk, and the extracranial portion has been divided into four portions. But however, at the CV junction, it has been divided specifically into three in order to emphasize the importance of the segment between C2 and C3. So here, the V1, that is the vertebral artery that after origin arising from the transverse process of C3, it encounters a significant bend, a superior as well as a medial angulation to a variable extent in different situations, in order to compromise what is called as a high riding vertebral artery in certain cases. So this is the segment of the vertebral artery that is before it enters into the C2 transverse foramen, and this is termed as the V1 segment. And the high riding vertebral artery can be assessed by measuring different heights, which we are going to discuss in detail later. And once it goes into the C2 transverse foramen, and after it exits the C2 transverse foramen, the V2 segment, that is the portion that is between the C2 and the C1 transverse foramen. So usually, initially, it curves posterior, lateral, and superior, and then again turns medial, superior, as well as anterior, in order to enter the C1 transverse foramen. And this is a redundant loop. Usually there are two redundant loops. There is one between C2 and C1, as I just described, and the second one between C1 and occiput, as I'm going to tell later. So these redundant loops help in the excess mobility that is there at the CV junctions, in order and allow this artery in order to compensate for this excess mobility as well as rotation that happens at the CV junction. After its exit from the C1 transverse foramen, the vertebral artery again jumps superiorly, posteriorly, as well as laterally, and then curves in a smooth manner medially and anteriorly in order to enter the groove on the superior portion of the lateral part of the C1 posterior arch. And this is the vertebral artery groove, and through this groove again it enters into the dural foramen between the occiput and the C1. So approximately measuring the entry of the dural into the dura is approximately around 1.5 centimeters from the midline, and that is one important thing. Whereas this vertebral artery groove is approximately 2.5 centimeters from the midline. Similarly, the lateral edge of the dura is to the vertebral artery origin from the C2 transverse foramen, that is at the superolateral junction of the lateral mass of the C2 or the articular pillar. So that is around 1.5 centimeters, as well as the loop, the vertebral artery loop is around 2.5 centimeters from the lateral margin of the dura, which is relatively, very arbitrary, because there may be significant variations in different people. So despite the groove, the vertebral artery, actually the occupancy ratio is significantly variable. At C1 groove, it's around 45 to 71, as well as in the transverse foramen, it may vary anywhere between 10 to 80%. So in the transverse foramen, which can be identified based on in the MRI as well. So as much as it is important to know the vertebral artery anatomy in the normal course, it's also important to understand the anomalies and variations, because they are quite frequent. Though they are around 2 to 3% in the normal population, it can be encountered. But in the presence of a CV junction anomaly, the amount of anomalies can extend up to 20%. And especially in the presence of an occipitalized C1, the incidence of vertebral artery anomaly or a variation can be as high as 66% and even 100% in some series, as has been told. So there are different type of anomalies that have been described. Of course, one of the commonest thing that we find is the variation in the size of vertebral artery. This can be seen even in the absence of any underlying bony abnormality as well. There can be an equal sized vertebral artery. There can be an asymmetrical vertebral artery with adequate lumen on both the sides, with dominance on one side. Predominantly left side is dominant in 50% of the cases, and right side is dominant in approximately 25% of the cases. So it is more often a left dominant vertebral artery. And there can also be a bilateral asymmetrical vertebral artery with a hypoplasia on the left side, that is the lumen coming to less than 10% of the original lumen. So in those cases, the flow is not significant enough. Whereas in very small percentage of cases, there can also be a total aplasia or an absence of the vertebral artery on one side. So again, what is relatively less frequent and uncommon is the true anomalies. That is where the vertebral artery itself has anomalous in its origin or its course, irrespective of the underlying bony abnormality. There can be a intersegmental artery, persistent first intersegmental artery, or a fenestrated artery, or an abnormal posterior pica origin, all of which will subject the vertebral artery to course below the posterior arch of C1, medial to the C1 pedicle, and as well as in front of the lateral mass, as you can see in all these pictures. So these are the type of incidences that we should be very careful in identifying preoperatively. Of course, fortunately, the most common vertebral artery anomaly that we see is a hypoplastic vertebral artery. What is more important to identify is the vertebral artery change in the course in the setting of an occipitalization of the atlas. So this has already been highlighted in brief by Dr. Mihir, and I'm just going to enumerate on this. So there are different variations. The type 1 and type 2, as you can see in both these cases, the vertebral artery actually courses in front of the lateral mass in type 2, as well as in front of the C2 body itself, below the lateral mass of C1. In type 1 variation. So in both these cases, actually access to the C1, C2 joint may be quite difficult, and vertebral artery mobilization may be required in order to access the C1, C2 joint. Fortunately, the most common type is the one where the vertebral artery passes through a separate bony groove within the occipitalized lateral mass, as well as enters directly intracranial. So it is not encountered anywhere in the operative field when we are accessing the C1, C2 joints. And this is seen in around 60% of the cases. Of course, in type 4, in around less than a very small percentage, the vertebral artery is completely absent, like an aplastic vertebral artery. It's also important to note the vertebral artery differences in the setting of a congenital atlantoaxial dislocation. Of course, the most common finding that we see is the absence of the redundant loop that I was discussing earlier. So the redundant loops both between C1, C2 as well as occipit C1 can be obliterated, which is called the stretched loop sign. So this can be seen especially in cases where there is a significant retroverted axis as well as some amount of a rotatory abnormality. What is more important in assessing the high riding vertebral artery is it is not just a high riding vertebral artery, but because there can also be a significant variation in the medial extent of the variation, that is the medial wall itself. So it is not just a high riding vertebral artery that we need to assess. So we need to measure, apart from the isthmus or an internal height, we also need to measure the medial, the thickness of the vertebral artery groove lateral to the pedicle, or the pedicle thickness medial to the vertebral artery over this, as it is shown in the diagram. So again, based on this, there have been several classifications. I'm not going to go into the details, and it can be a wide the medial pedicle with a narrow high riding vertebral artery, or it can be a narrow with a high riding vertebral artery. So both these variations can be seen, which is important to identify before planning for a vertebral artery, for planning for a fixation in this particular region. Why high riding vertebral artery has been defined or classified into several types. Again, not going into the details, it is important to identify that the medial incurving of the vertebral artery, if it extends beyond the middle of the C2 pedicle, this constitutes as more than type 3 or type 4. And both these types are actually where the screw is going to come in the way of the vertebral artery is going to come in the way of the path of the C2 screw in both these situations. So just to summarize, what we have to understand in the setting of congenital atlantoaxial dislocation is that the vertebral artery can change its course based on the bony abnormality. It can be more superficial, especially because of a retroverted axis. Because of the rotatory abnormality, one side vertebral artery can be more medial to the midline than to the other side. It is important to identify these two situations in order to prevent any kind of injury during the exposure, which is in the superolateral portion of the articular pillars. Of course, the upper border of C1 at the V3 portion, that is the vertebral artery at the upper border of C1, again due to a rotatory abnormality, maybe closer to the midline on one side, which is again important to keep in mind. Apart from the occipitalized atlas and the high riding vertebral artery, which we already discussed, a prominent medial loop of V3 segment, that is the vertebral artery above this level of the C1 between occiput and C1, that is important to identify in those cases. Coming to the iatrogenic injury and management, vertebral artery injury, as has been mentioned, can be a catastrophic iatrogenic complication of any cervical spine surgery, predominantly at the CV junction, where it is one of the most commonest reasons. There can be serious consequences, which can include intraoperative significant hemorrhage, resulting in even hypertension as well as cerebral ischemia, as well as postoperative complications like fistulas or pseudoaneurysms, which can also lead to embolic phenomena and cerebrovascular accidents. The incidence is, however, very rare. In the posterior surgery, the most common incidence is encountered in a C1, C2 transarticular screw, which is around 4 to 8%. However, there is no reported vertebral artery injury for a lateral mass screw, which are considered to be quite safe as far as the vertebral artery injury is concerned. And as has been mentioned, most vulnerable to vertebral artery injuries are most vulnerable to, at anterior to C7, whereas in the lateral part of C3 to C7, as well as posteriorly to at C1, C2. So as has been mentioned, during exposure, we have to be very careful, and it has already been stressed by Dr. Mihir, and it's been explained beautifully how to do this. So I'm not going into the details about how to expose the expose the bony anatomy, preserving the vertebral artery in normal cases. But of course, whenever there is an abnormality, we have to make sure that vertebral artery course is identified and mapped correctly before we can continue with the exposure, and especially using cautery in the superolateral portion of the facet joint should be avoided in all these cases. So coming to, again, vertebral artery injury can happen during screw insertion as well. Of course, this can be avoided. This can happen due to the high-speed drill as well as while putting in a tap or a screw. This can conclusively be avoided by proper preoperative evaluation, as has been emphasized several times during this session. And also by choosing the screw wisely, like using a short par screw, like Dr. Mihir was telling, or even using navigation assisted screws, where we can put, say, even in the presence of a high riding vertebral artery or in the presence of a narrow pedicle, we can avoid the important vascular structures and place a screw quite safely. Of course, what is going to happen in case of a vertebral artery injury, the treatment goals is, of course, immediately to achieve control of the hemorrhage, prevent any acute central nervous ischemia, and of course, prevent postoperative complications such as embolism or a pseudoaneurysm. Of course, vertebral artery injuries can end up in one of the three. Either it can be a primary repair, bypass surgery, or a sacrifice. Just to enumerate this, I'm just going to go through a small flow chart in order to make clear what is the management protocol if one intraoperative vertebral artery injury happens during exposure. Of course, it is very important to know whether it is a dominant or a non-dominant side or a co-dominant side, and a preoperative angiogram would have helped us significantly in this particular matter. Though as we were mentioning, though the non-dominant or a co-dominant vertebral artery can be guessed on a size of the vertebral artery on a preoperative MRI, a presence of a DSA or an angiogram, which will actually tell us the backflow or the amount of backflow that can happen during unilateral vertebral artery injection, is the ideal method in order to assess, especially if there is an intraoperative vertebral artery injury, for us to evaluate and assess the consequences of sacrificing one vertebral artery in case there is an intraoperative injury. So if there is an injury, in either case, it is always better to have a good proximal as well as distal control. And it is very difficult in some cases. Sometimes it can be achieved, especially if there is a bleeding. The first thing that we have to do is control the bleeding at that particular point by a tamponade, by using any hemostatic agents, or by even significant amount of some pressure applied on that point. And because it's a very small area, it's quite difficult to obtain any superior or distal control. So if the injury is at the level of C2, the superolateral exposure of C2, the vertebral artery has to be exposed by drilling of the C2, C3 joint lower down, in order to expose the lateral part of the vertebral artery over there. And of course, in some cases where the injury is above the level of C1, the vertebral artery can be exposed at the level of where it exits from the C2 transverse foramen, or whether when it is entering the dura. In case, sometimes even the dura can be open in order to achieve the proximal control or a distal control in these cases. However, this is not always necessary. In case if there is a good retrograde flow, or of course in case if it's a non-dominant or a codominant vertebral artery, and we are able to achieve these kind of controls, and if there is a good retrograde flow even after blocking the proximal control, the artery can be safely sacrificed or tamponated. If it is an hypoplastic or an aplastic hypoplastic vertebral artery, then obviously it can be easily sacrificed. So if there is no poor or retrograde flow, then we have to evaluate whether primary repair is possible, especially if it's a dominant vertebral artery. And primary repair should be the first option whenever there is a dominant vertebral artery injury. And of course, if it is possible, primary repair should always be attempted along with a vascular surgeon. If primary repair is not possible, of course, we have to tamponade and probably abandon the procedure in order to save as much time as possible to prevent any cerebral ischemia. Appropriate measures have to be taken, discussing with the anesthetist, in order to preserve cerebral function. Probably even hypothermia or something like that can be advised. And as early as possible, the patient has to be rushed to an endovascular suite in order to attempt any endovascular repair. If endovascular repair is not possible, probably a bypass can be considered. But of course, that can be done only as a delayed cases. Nowadays, bypass can be attempted only if there is a pseudoaneurysm or some kind of case where vertebral artery cannot be sacrificed. In all these cases, postoperative DSA, immediate postoperative DSA especially, is preferable if there has been a tamponade, or if the vertebral artery has been sacrificed, or if there is a primary repair that has been done during the surgery, in order to assess the adequacy of either of these techniques, whether the repair has been done adequately, whether the patency is maintained, or whether there is any development of a pseudoaneurysm following tamponade or any kind of a sacrifice that has been done. Of course, during screw insertion, the decision making is quite simple, because because the vertebral artery is injured within the bone. Probably proximal or distal control is not very important to be achieved. If it is a dominant vertebral artery, then probably we will have to change the screw trajectory, or an alternate screw can be used, and use bone wax to control the bleeding. Of course, immediately post-operative angio has to be done, and endovascular repair or bypass has to be planned. If it's a non-dominant or a codominant, then actually the screw can be inserted either directly or after using any tamponade or a hemostatic agent. And then again, post-operative assessment has to be done. There are several general measures to be followed intraoperatively. Of course, anesthesia team communication. We should not panic. We should send for a vascular surgeon, arrange blood products, ensure the head is in neutral position so that the contralateral vertebral artery is not occluded. Digital pressure has to be applied, large pieces of hemostatic agents, in order to control the bleeding. Of course, post-operatively, we have to keep, even if the patient wakes up without any neurological deficit, we have to keep a close post-op monitoring in order to see for development of any gradual thrombosis of an injured vertebral artery or any embolic phenomena. Look for any lateralizing signs. Any antiplatelet therapy has to be started. Nowadays, it's slightly controversial because there are several studies coming out that role of antiplatelet therapy is not very, very important in management of vertebral artery, especially in the post-traumatic situation. However, in all these situations, it's always safer to start on antiplatelet therapy if there are no contraindications, started as early as 6 hours after the surgery. In cases where antiplatelet therapy has not been used, there is almost 3-fold increased risk for vertebral basilar insufficiency or a stroke, or a 10-fold risk of poorer outcome if antiplatelet therapy is not started. Postoperative neck movement should be restricted, and of course DSA has to be done in order to identify and treat pseudoaneurysms, as was already being mentioned. Fortunately, majority of the vertebral artery injuries, even on the dominant side, usually do not result in significant postoperative neurological deficits. Even, for example, in a transarticular screw, as has been described by Wright et al. So even though there has been an incidence in their series of around 2.2% injury per screw, the incidence of focal neurological deficit was hardly 0.1% per screw inserted. That is around less than 5% of in cases where an intraoperative injury has been found. And this actually raises questions as to how effective or how aggressive we have to be about management of vertebral artery injury during these intraoperative, that happens during intraoperative period. But nevertheless, it is always better to be aware of what are the options available in order to manage intraoperative vertebral artery injury. So just to conclude, these are the 4 A's that we have to remember. We have to understand the anatomy of the vertebral artery, both normal anatomy as well as the variant anatomy in a particular case. We have to assess the preoperative status correctly. We have to avoid any vertebral artery injury by choosing appropriate thing. And of course, vertebral artery injury, if it is there, what is the action that we have to do? Thank you.
Thank you, Umesh. So while you unshare your screen and we share Dr. Naresh's talk, vertebral artery injury remains only one of the problems that one can face in cervical spine surgery while posterior instrumentation comes up. Naresh is going to talk to us and tell us about various aspects of problems, complications, and salvage modalities while dealing with posterior cervical instrumentation. Over to you, Dr. Naresh Babu.
We are live now. Thank you, Vishal. Thank you, SSI, for giving the opportunity. I know it's very difficult to complete the last topic. I just summarize few of the complications without which the webinar doesn't end. The cervical post-instrumentation, it's greatly evolved over the past half a century, from simple wiring to suture techniques to screw fixations. And the understanding of spine mechanics that actually evolved so well, and the advances in the imaging has also made this real-time assistance possible during operation theater. But there are many reasons by which we get complications. This could be biological reasons related to infection, porosis, pseudoarthrosis, or patient-related challenges. Or it could be biomechanical failure or some decision-making issues while selecting a proper technique, or it could be execution issues. So most common complications what we face in posterior cervical fixations are related to the positioning problems. So we all know that how to position the patient, and we should be very careful in maintaining and reducing the venous blood flow by elevating the head and arms tucked in, the knees flexed, avoid sliding, head and neck above the heart level, and taking care of the face, nipple, abdomen, and the genitalia. These are the few things which actually provide us to give the head support perfectly, so that the patient doesn't end up in unnecessary complications due to the procedure. Horseshoe or skeletal traction can be used to fix the spine. Especially when you are actually doing a C1, C2 transarticular fixation, it becomes very difficult or important to maintain the angle. And also you should be careful in positioning the head so that we don't fix the C1, C2 in a torticollis position, which is tilted to one side. That is one important thing which we need to avoid while doing these surgeries. While we are doing a occipital cervical fixations, it's very extremely important you position the patient and you fuse the patient so that the eyesight will be maintained. So don't fix it in too much of extension or too much of flexion. And eyes are well protected and covered with the pads. Eyes are very important in positioning the patients, and this is the way we actually also position the patient for occipital cervical fixations, where the head will be facing down and the vision is parallel. So why it's important is, so there are two ways patients can develop post-operative visual loss in posterior cervical surgeries by pushing the patient prone. One is by anterior ischemic optic neuropathy, wherein due to pressure of wrongly positioning the patient, the compression forces can lead to anterior ischemic optic neuropathy. When there is acute blood loss, which causes ischemia to the optic nerve, the patient can end up in a posterior ischemic optic neuropathy. So So these two things needs to be avoided. So how do we avoid is by careful positioning, avoiding eye pressure, and avoiding the corneal abrasions. So we should minimize the head dependency. These are the high risk patients. We need to identify them and then protect them very well. The patients with glaucoma, patients with diabetic retinopathy or hypertensive retinopathy, these patients are prone to develop post-operative visual loss. There are few complications related to the skull traction, whether you can patients can develop pin tract infections or dural penetration leading to leakage of CSF. Sometimes inadequate intracranial pin penetrations are also reported, resulting in serious injuries. In a review of 179 patients, the loosening was also reported. The complications were quite common in pediatric patients compared to the adults, and there is also a risk of over distraction when you use these methods in the patient. This is one of the patients reported with a brain abscess after a rare complication with the skull traction pin in a halo patient. Other most common complication of posterior instrumentation is infection. Though with the advent of titanium, theoretically the infection is very less. So the affinity of bacteria to titanium is less compared to the stainless steel. There is inadvertent, unintended where debris can develop, and patients can have pseudoarthrosis because of the debris coming in the way with the fusion. One way of avoiding instrumentation, infection following instrumentation is to use the in-drop vancomycin, which is strongly proposed for deformity surgeries nowadays. This can be used as a local prophylaxis. The implant failure is other most common problem. The quality of the host bone, the conflict between the quality of host bone and the implant is the one which decides the failure. The early fixation failure is very important to identify, because the loosening before attempted arthrosis really puts the patient into a lot of problems. Adjacent segment degeneration in cervical posterior fusions. Its reported incidence is 3.4% per year and 5.9% at 2 years. This could result from poor bone quality, paraspinal musculature, or ligamentous dissection or instrumentation failure. Though ligamentous integrity and the muscle dissection has been proposed as one of the main reasons for adjacent segment degeneration. The adjacent segment degeneration in cervical spine is quite commoner with anterior procedures than the posterior. So the motion also plays an important role along with the dissection of the posterior muscles. Zia has found that when you extend the fusion to C2, it reduces significantly significantly reduces the fusion. And pseudoarthrosis is most common in even in the technically.
He's got a lot of weight and some appetite loss.
So failure of fusion is found in 20% of PCF, posterior spinal fusion patients. It's quite common in the caudal end of the fusion constructs. The patients typically present with the neck pain and progressive pain while movement. The incidence of fusion was quite less. Incidence of pseudoarthrosis is quite less when the fusion extended to T1 in long fusions compared to those who are extended to C7. So when we analyze the screw-related complications of transarticular fixation of C1, C2 TAS fixation, Vishal has extensively spoken about this one. We had lateral penetrations were quite common. The 29% with the 49 screws were reported in a systematic meta-analysis. And they all resulted, they analyzed this according to the skin incision location. I didn't find any difference with the skin incision location. And the lower screw malposition rate point in when the biplanar fluoroscopy was used. And there is no significant difference when you use a cannulated or non-cannulated screws. In transarticular screw fixation, vascular vertebral artery injury was also reported. 34 vertebral artery injuries episodes were reported in 32 patients. Of these, 8 cases symptomatic injuries, and 5 patients resulted in AV fistula. The significant difference was noted in this quite lower in the patients with the cannulated screw insertions. The screw breakage is also quite common in transarticular screw fixations. So when you use the thicker screws of more than 4 millimeters, the failure is much less compared to the cannulated screws. The screw-related complications of subaxial cervical spine fixations. When you compare the lateral mass versus pedicle screws, coming to the lateral mass screws, the nerve root irritation and violation was quite less in Hodan's technique than the Magral and Anderson's techniques. But Roy-Camelli technique was found to be the best to avoid nerve root injuries in C3 and C4, whereas the Magral technique was quite safe and to avoid nerve root injuries in C5 and C6. It is interesting to note that none of the patients with less than 14 screws have developed any kind of vascular or neurological injuries. So, but we end up in fixing unilateral lateral mass rather than bilateral ones. Lateral mass screws, 3.6% incidence of nerve root injuries were reported with Roy-Camelli and Magral techniques. And Cho has reported one case of vertebral artery injury even with lateral mass screw fixations. This is quite interesting. This happened with usage of a quite longer screw, which has actually penetrated the vertebral artery, vertebral foramen, and led to vertebral artery injury. Facet violations are the quite common complications of the lateral mass screw fixation. Coming to the cervical pedicle screws, perforations of pedicle screws. This is the most talked about complication of pedicle screw fixations is pedicle perforations. It ranges from 1.1% to 29.8% in different series. 3% in the computer-assisted group and 8.6% in the conventional freehand group. Computer assistance and real-time imaging is known to reduce the incidence of perforations. Coming to the vertebral artery injury, there are different series presented at different rates. In Abumi series, there is one patient out of 180 cases, and Yakova has reported one case in 144, and Nakashima has 2 cases in 84. So rate of nerve root injury was 0.31% per screw and 1.24% per patient, which was not found to be significantly different from that of lateral mass screws. So we had a nice lecture on vertebral artery injury, how to pick it up. The few technical tips when you encounter a vertebral artery injury during the procedure. Our aim is to achieve the hemorrhage control and avoid ischemia to the central nervous system and to prevent post-operative complications like fistula or pseudoaneurysm. So primary repair, if possible, is the best choice. What we should do while the vascular surgeon trying to repair the vessel, the head should be kept in neutral position. Any extension or axial rotations can lead to occlusion or contralateral vertebral artery. The head should be kept in neutral while the repair process is going on. And digital pressure can be used to obtain the homeostasis. And you should avoid using small pieces of hemostatic agents because there is a tendency for these things to embolize and leading to stroke. Temporary aneurysm clips, when they were placed, they should be opened up prior to the completion of the repair. Otherwise, there is a high chance of air embolism happening in these patients. So these 2 things are very important. Primary repair, avoiding keeping the head in the neutral position while the repairing is going on. Avoid small pieces of hemostatic agents, and temporary clip should be removed to prevent air embolism before the completion of the closure. So venous bleeding is typically encountered during exposure at C1C2. The tamponade is the best treatment. We should use large pieces of patties or Surgicel to control this bleeding. So when you encounter pulmonary air embolism, it has been suggested to copiously irrigate the surgical field to dilute the effect of embolism. The few things about occipital cervical fixations, the placement of occipital plate, there could be unintended urotomies can happen. The placement of screw is all that is necessary to stop the leak. When there is a leak happening through the occipital hole, you need to place the screw and that stops. If it doesn't stop, the bone wax is the best one. If you suspect injury to the cerebellar cortex, that is a bad sign. This can lead to suboccipital hematoma, and that can be potentially fatal. And emergent neurosurgical intervention has to be done. With a longer screw hitting the cerebellar cortex is a dangerous sign while putting an occipital screw. So to conclude, the complications can happen because of the biological failure leading to with leading to infection, pseudoarthrosis, or osteoporosis, implant-related lesions, or biomechanical failures. We should avoid decision-making mistakes and execution issues. Thank you very much. Vishal, over to you.
Thank you, Naresh. Wonderful illustration of all the problems that one can actually see across. And I'm sure with these, the mind is aware, the eyes can see, and the brain can prepare. So I think this is the best example of how one can actually be prepared with the problems that one can face in CV junction surgery. But before we move on to anything else, there are a couple of questions that came across from some of the delegates via Dr. Gautam Zaveri. But to start with, Ayush, yours was the first talk where we started about subaxial lateral mass fixation techniques.
Yeah.
So there was a question from one of the delegates. Which technique do you follow, or there is a specific improvisation that you have done? Do you follow Magrel's technique, you follow Ann's technique, or you follow Anderson technique while using lateral mass fixations?
So what I basically follow is what I showed you. So you have to, all those techniques are equally good, but basically you have to understand that each patient is different, each anatomy is different. So you should study the, if possible, the CT or the X-ray. And the most important thing is understand the craniocaudal direction, and best way to get the direction is get a lateral shoot to make sure you're on the right trajectory. If you are starting new, start in the middle of the box back, because that is a easy trajectory to get. If you want to get a better screw, a more bigger screw, you can start in the inferior corner of the lateral mass box, and then you need to really angulate it well to get to the angle which I showed you in the three-dimensional structure. Right. And maybe most of the time you might be able to get a bicortical hold, and that will give you a really strong.
Also, Ayush, we were discussing about a problem called dorsal burst out. Say you are doing a C3 to C6 or C3 to C7 fixation in a patient with laminectomy and lateral mass fixation. What do you do as a salvage if your C4 or C5 lateral mass gets burst out? Do you leave them and just finish C3 to C6? That's question number one. And question number two, what do you do if your endpoint anchors burst out? If your C3 burst out and the last C7 bursts out, do you do a pedicle screw? Do you do wiring? Or what are your salvage options in those situations?
So if you're in the middle of the construct, most of the time you can leave it safely. That is the way it is. But if you're at the proximal and distal end, you can try alternative method. See, even if you're burst out, you can have one more attempt. I won't say many, but once you can try one more angle, a different angle. And as I told you, if you understand the three-dimensional anatomy, you have one more shot. And that's what I believe. Okay, so you can try.
Very important point. Very important point. I think this is one line that we all must understand, that Ann technique, Anderson technique, and Magrel technique have different angulations, different length, and some of them go straight, some of them go oblique, some of them go caudal, some of them go cranial. And in knowledge about all these options is absolutely mandatory. Not only because one burst out doesn't take away all the other options. You can choose Ann's technique as the most salvageable thing, and it's extremely important that if you just burst out your lateral mass, pedicles are always there. And that's why the understanding of technique of what Upendra mentioned is also very important in your armamentarium. Upendra, question to you. So if one of your patient's pedicle gets laterally burst and your screw is lying in the vertebral artery foramen, what do you do if the vertebral artery is injured intraoperatively? And what do you do if you discover that screw is lying in vertebral artery foramen postoperatively? Both the questions, please.
Yeah, we do have our share of lateral perforations. We have had probably around 5 or 6 patients under follow-up for a grade 2 vertebral foramen perforation. A few of them we have had vertebral angios also. We can see that the vertebral artery kinking, but the flow was there. They were all asymptomatic for it. We have had recently vertebral artery injury intraoperatively also. In this case, it was a smaller, the non-dominant one with the MRI which we had seen, and we blocked the flow by putting the screw directly onto it. Post-operatively, we didn't have any problems. The patient is under follow-up. It's around 4 months now. So we are keen to follow up with follow-up angios and see if there are any aneurysms for the patient.
Right. Interesting. And then one more question. Umesh, what do you do a patient who's got vertebral artery injured? You have somehow been able to manage the intraoperative bleeding. what is your post-operative protocol if you see a patient who's asymptomatic coming into your clinic who had an incidental vertebral artery injury and is asymptomatic today? Do you follow them up with their aneurysm formation, and do you do something else for them in the future?
Yeah, usually yes. Usually at least one follow-up angiogram. A CT angiogram is sufficient in order to rule out any delayed pseudoaneurysms, of course. But I don't think more than 6 weeks we need to monitor them. I mean, so far we have not had any case who have come back after 6 weeks. For that matter, even at 6 weeks also, whatever in one case that we had done, we didn't find any kind of pseudoaneurysm that was developed. But yeah, 6 weeks is something that we think is ideal for monitoring or evaluating any delayed complication that has happened, either a delayed thrombosis or delayed pseudoaneurysm that has developed. But if at 6 weeks, if it is normal and the patient is asymptomatic, probably that can be the end of the follow-up period, is what I feel.
Right. So with this, I think I would just rest my case there. Posterior cervical instrumentation techniques. We started with fixation techniques in the subaxial spine with lateral mass fixation technique by Ayush, supplemented by technique of doing cervical pedicle screw by none other than Upendra. We also have the senior guys, Dr. Mihir speaking about C1, C2 fixation options. Transarticular screw was discussed about the feasibility planning in detail, followed by Kshitij enlightening us about occipital fixation options and problems that one can encounter. Dr. Srivastav gave us a highlight about fusion techniques in CV, how to do and how to attain wonderful fusion. Naresh highlighted about various problems and complications one can face in posterior cervical instrumentation in detail and illustration of problems one can face to keep them ready about the problems. And Umesh highlighting us about the vertebral artery anatomy and problems, how can one avoid such problems in CV junction and cervical spine surgery. With this, I thank you all the faculty members for being around here. Thank you ASSI for organizing this for all of us. I'm sure we have all learned so much more, and there's so much more to be known from here. Over to you, Dr. Gautam Zaveri. Thank you all again.
On behalf of the Association of Spinal Surgeons of India, I would like to thank Vishal for moderating a fabulous session. And to each and every one of the panelists, all the talks were way above par. They were fantastic talks, very clear elucidation of techniques. And as Vishal said, not only the audience, but the panelists as well as me, we have learned a lot in this session. All of you who want to follow this session, you could go within a couple of days. This will be up on our YouTube channel, and you could redo this session so that you can learn and master these techniques at least by looking at it. As Vishal mentioned, when you want to do these kind of techniques, knowing the anatomy and the abnormal anatomy is absolutely vital. You should know when to do the surgery, when instrumentation is required, when it is not required, how many levels you are going to fix. These are the basic biomechanics which you must learn. And then comes the third phase, which is the surgical technique, all of which have been covered in this series very well. And with that, I thank everybody and wish you a very happy remaining Sunday evening. Enjoy yourself. Good night.
Thank you so much.
Thank you.
Thanks, Neeraj. Thanks, OrthoTV, and thanks, Ashok, for organizing this. You have been the backbone of all these webinars. Thank you so much again.
Thank you all. Bye-bye.
Bye.